Good morning, everybody. We're going to get our session started momentarily. I'd like to welcome all of you on this beautiful Alberta morning. If you haven't done so already, take a gander at those beautiful mountains with the sun coming off them. Should be a good backdrop to the presentations that we hear today. My name's Joe McGilvery. I'm the Executive Director of the Calgary Rural Primary Care Network. We put this session together because our network is very much poised on reforming primary care. I was talking to Dr. Kinney on the way in today. Canada ranks about 23rd or 20th in primary care outcomes in the world. It's not an acceptable position. If we were 23rd in the world in hockey, we would all be depressed. So I feel very depressed that our country is in that situation. And the topics are food for you that are going to be working to help make that different. Professionalism, which Dr. Kinney will cover, and primary care practice, and we're very pleased that Dr. Baylor's with us. So I'm going to call on Dr. Cunning to introduce Nuala to you, and many of you already know her. So Les.
Welcome back, Joe. Joe just got back from overseas last night, and it looks like he got a European haircut while he was there. There are in my professional life, and I promise to keep this short, so don't panic, a number of people who have made a huge impact on the way I view my profession, the way I practice, and the way I think about my relationships to both my colleagues, my community, and my profession. And I first was introduced to Nuala a number of years ago. And I remember at a room in the Palliser with 4 or 5 of us watching her brain work, where began to articulate thousands of years of tradition in our profession, and what that meant personally, and what that meant to our communities, and what that meant to our profession generally. And it was stunning in the way that we need to revisit, I think, especially now when what dominates our thinking is the way we're organized administratively and in a government sense. And it seems to be at the top of the table, rather than the deeply held, long-standing traditions of the quality care, our relationship with patients and communities. I would be here for the next hour going over her bio, but she's a physician, a pediatrician, and has written a few articles here and there. I have pages of this phenomenal CV, but her nationally recognized educator, physician ethicist, has been recognized both internationally and nationally for the work she's done in articulating our personal and professional responsibilities. And I'd like to introduce Nuala to you. She has traveled many different paths, and I think is a unique individual. Thank you.
Thank you, Les. That's good. Am I talking too loud? Am I spitting? I once did so you do need to know about me. I am a pediatrician. I am a Roman Catholic sister. So I'm a sister doctor, or a doctor sister, depending on where I am, what I'm called. So between being a religious whose ministry was medicine and being a pediatrician caring for children, and I did special training in oncology. I did not become a pediatric oncologist. I'm a generalist. But because I did oncology and because I was chief of 2 children's hospitals, have done a lot of end-of-life care with babies and children. So ethics and ethical issues, as the kids say, ta-da, they just come naturally because of who I've been. And I thank Les for saying that some of my passionate commitment to the ministry of healthcare, this is not, you don't have to be Catholic to share this. Healthcare has been understood as a calling, and I'm going to try to, without it being, you know, too sweet and sentimental to be real, kind of evoke for you the incredible tradition to which we belong as physicians. And then let's talk a little bit about where we are today, okay? So that's who I am, and here I am. I did have the interesting, this is I left Halifax on Monday morning because I'm on the board of Covenant Health, which, as you know, is all Catholic healthcare facilities in Alberta. We had the annual meeting, and Premier Redford spoke at the dinner on Tuesday evening. Her theme was her focus on primary care, which is family care clinics. Right. Now, some of you may be freaking at that notion, but let me tell you, and I hope by the end of my conversation, I think you are in an enormous position to influence when you actually have a premier who gets the importance of primary care. Now, her vision of how to do it, you may have to work with, but she gets the importance of the concept. And you need to understand this is crucially important, because the second general observation, in the 12 years I did bioethics full-time, and I was Deputy Minister of Health of our province for a year, not a career choice, a duty assignment. But ethics and public policy are a special area of interest. That's interesting, being a doc who has an interest in ethics and health policy. And I can tell you this, so I'm telling you who I am. I'm a tertiary care generalist pediatrician, have run my last 10 years in clinical practice, I was the chief at the Children's Hospital at the IWK in Halifax, Nova Scotia. So I'm on the specialty end of this. And I tell you, gang, all of the literature about all issues of health system sustainability and efficient, effective, appropriate care throughout the world show you if we do not have a robust primary care system, the rest is dead in the water. Okay? A system that is dominated by specialty care, the specialists, the disease-oriented individual folk, is doomed in terms of fulfilling the hopes and dreams of patients for good quality care. So just so you know, I don't come from the world of primary care. I come from the other end, but my absolutely firm commitment, my training as a pediatrician and my practice was always linked to assist primary care physicians in their obligations. I help you when, in fact, your need for care of complex and difficult diagnosis in children was exceeded. So that's a little bit of the perspective that I'm sharing here. So a doc deeply interested in the moral and ethical tradition, very proud of being a doctor, though not always proud of all doctors. Okay? But interested in just health systems, that also comes from my personal religious background, and yet deeply, deeply committed to what you do. Okay? So let's see what I might be able to do here. So my goals for the next little while, 35, 40 minutes, because I want us to have a chance to have conversation back and forth. I want to do three things. I want to describe what I understand from health system reform projects and trying to help out Les and Joe, and I was, what was 5 years ago that I came and learned a fair amount from you folks about primary care. So let's define some features of modern primary care. In a sense, that would be the history taking, if we made the analogy with the patient, right? Then let's go back into the longer history, not just the presentation, but the longer one, and reflect on the traditional ethical obligations of physicians and what I'm going to describe to you as the protective power of professionalism. To me, the notion of medical professionalism has protected us to be at our best, because this is the fundamental ethical conflict for docs. We make our living from the sick, the suffering, the dying, and the worried well. I can assure you that as a general pediatrician and chief of a hospital, I could have convinced parents to do anything with their child. Dangerous position to be in. Trusted, have access to all kinds of power and authority and scientific advance, and yet know the fragility of what you were dealing with. These babies and children and their lives and their deaths. I mean, it's a so on the one hand, we're the heirs to a 2,400-year tradition. Goes 400 years before the Christian era in our original Hippocratic roots, that from the get-go recognized that our commitment is to the welfare, well-being, we now use the term best interest, and we'll talk about that a little bit, of the patient. That's our when we act as doctors, our primary obligation is to do the best in our doctor role for the patient. But the conflict that we're always in is we make our money from this. So a formal profession of you can be promised that when you come to a doctor in the allopathic, that's our scientific tradition of medicine, we will act for the patient's interests. We may have to declare a conflict of interest. We will always have to be conscious. And these are not, these are not just financial conflicts. When your beeper goes at 2 in the morning and you got to get up because you're home, that you're now on call, it is not in your personal best interest to get out of bed. But if you're on call, that's your duty, right? If, in fact, you discover that you are on call the same day that your grandparents are having their anniversary, unless you can change and get a colleague to replace you, I'm sorry. But your obligation, it's not in your personal best interest to miss the wonderful occasion of your grandparents. So you need to understand from the beginning, even though Hippocrates and the early development of modern scientific medicine didn't have lots of good science, it had some, and it had vulnerable patients. So the fundamental commitment, 2,400-year commitment we've made, is to act in patients' best interest, but recognize that, in fact, we can manipulate patients. We can, in fact, privilege our advantage rather than the patient's. And that's going to be important when we look at the third kind of concept here, which is what kind of challenges do we see today to this enduring notion of professionalism, and where are they coming from? Because as my good Irish grandmother would tell you, when I say you're the problem, see these 3 little fingers? They're pointing back at me. So let's look at, there are challenges to professionalism, and I hope I can outline some of those, and I hope I can help you share my passionate commitment that medicine and our long-standing tradition, what we do is not just a job. If you think it's just a job, then get out of it now. It isn't just a job. It is a job, but it isn't just that. So let's look then at these 3 things: modern primary care, our tradition of ethical obligation, and then particular challenges. All right, so from my perspective, there are at least these 4 kind of characteristics of primary care medicine. And let me make a comment. One of the things that I learned when I was working with Les and Joe as the PCN was set up, there's a literature on the reform of primary care, and then there's a literature on the reform of physician primary care. They ain't the same, right? You have to reform physician primary care if you're going to do the larger reform of primary care. But there are lots of folks who think this is only about the docs. And from my perspective, as you'll see by the time we finish this, that just won't be a reform of primary care because of the nature of practice today. But the features of general primary care. First, contact access for each healthcare need. Long-term person, not disease-focused care. There's a place that, if you're in Houston, you've got the Houston Cardiac Institute on one side of the street and a Houston Brain Institute right across the street. So the hearts walk over here and the brains go over here. I mean, and people don't see anything ludicrous about thinking in terms of those silos. Now that's an extreme, and it's a visual image when you stand there saying, what? But that is a manifestation of something that's happened to us in modern healthcare, right? this fragmented. We're going to talk about that, and we're going to talk about that in some of its collegial consequences. But what you folks are about, this is historically, because you're going to see, I'm going to say, are there challenges in the way you've allowed yourself to structure and be structured to first contact access for each healthcare need? What about long-term person, not disease-focused care? I'm sure there are some of you in this room, though a number of you look quite young, but some of you in the room, you actually have cared for patients, Les has done this, patients, their children, their grandchildren, right? You know them. You know if they come from Okotoks, where they come from Okotoks, where they're, you understand them not as a headache that's walking through the door, but as a person with a headache. And you know something about the person and the way in which they have an illness experience, not just a disease diagnosis. Okay, so primary care, first contact access, long-term person, not disease-focused care. What you have done historically is comprehensive care for most healthcare needs. Good family docs, primary care docs, family docs, my expression, do a little bit of everything. You're wonderful generalists. And of course, in a world where the generalist is a dying breed, going the way of the dodo, general internal medicine, there's almost no such thing now. And you folks are more generalist than general internal medicine. You're really the everything. You're the everything docs, right? And then look at this one. Historically, the primary care doc, family doc, did coordinated care, was the site of coordinated care when it must be sought elsewhere. When you can't do it, when you need the gynae, when you need the orthopod, when you need those folks, historically, the family doc made the consultation, right? And while the orthopod might do the follow-up, the surgery for the hip, you followed the rest of the patient. How is that changing? How is that changing? I can tell you the biggest problem as chief of a children's hospital in relation to primary care wasn't that our docs, family docs in Halifax didn't have privileges at our hospital. We had over 230 docs with privileges at our hospital in downtown Halifax. But there were 5 of them that we could identify who came to the hospital. Now, part of that is the change in your practice. But do you know the difficulty when families with a really good primary care doc choose to come to the emergency department for something, not an emergency, but for something that they should have seen their primary care physician for, and then the primary care doc's all in a snit because on Tuesday morning they don't know that this patient was admitted on Saturday. But the parents bypassed the family. So we had this very strange situation today of a history. Look at these features. If we did that, if you did that, man, would we have happy campers in terms of primary care. But even we ourselves, you know, like Pogo says, I have seen the enemy and it is us. Sometimes it is us. Now, what do patients want and need? If you look at this literature about health systems and health system reforms, it's 2 different kinds of issues. Still, patients and their loved ones want a certain number of interpersonal qualities from their doc, right? They want trust, that the doc is going to act for their well-being and welfare. That is still the enduring, and that trust is not just that the doctor has a moral commitment to act for them, but is technically and scientifically competent to do that, or will refer if they recognize their limitation. But without trust, there is nothing in medicine. And I don't care whether you're sitting at the bedside of a dying 14-year-old with an oncologic diagnosis or you're just diagnosing dementia in your own primary care practice with someone you've known your whole practice life. So, interpersonal qualities: trust, respect, and two-way communication. Okay, now, hold on to these qualities when we look at the challenges to modern professionalism and where they come from, because I'm going to tell you that we do need to, as again my good Irish Nana would, stand up on our hind legs and resist some changes to systems that are in fact obstructing the qualities we just saw about good primary care and obstructing the development of trust, respect, and two-way communication. But you, my friends, I don't practice anymore, so now it's you. You are engaging in practices where you have, in fact, altered respect, trust, and communication. And we all have to do a little bit of an examination, I think, here. Now, how about system qualities? Well, it goes with what we just saw. People want access when they need it. They want continuity of care. They want continuity of care. They want comprehensiveness, coordination, quality, and they want fairness. And they want fairness. Okay, so think of that. So the evolution of primary care, well, some of you in the room have lived this, so you're the ones who should be describing this, but general feature so we can do our ethical evaluation. For a very, 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 very long time in our tradition, there were solo physicians, an individual doc. And you're going to see this is important because the ethical tradition comes from the context with an individual patient dealing with an individual physician. But for a long period of time, solo physicians, all fee-for-service was the norm. I mean, we're talking hundreds of years in Western medicine. By the time we come to the 1970s, we begin to see a whole bunch of alternative organization and funding models. By the 80s, so 70s, it's the structure, where care happens, how it's organized, okay, site, all that. By the 80s, it's focusing on broadening the range of primary care providers. Okay, again, increasing complexity of care and the notion that all kinds of different expertise is necessary for the patient's needs. And then by the mid-90s, and this includes stuff that continued on early, your part of this continued today, primary care reform pilot and demonstration projects. Okay? Now, when I reviewed the literature on this about 5 years ago, when Les and Joe and I were talking, the fact of the matter is that there have been lots of pilots and lots of demonstration and lots of talk, but very little fundamental change in primary care. Now, you may feel you're experiencing lots of stuff at the edges, but we still, I think, have a way to go to make primary care the centerpiece of a robust healthcare system that meets patient needs and maps the qualities that I just described. That's some of the changes and the landscape in the real world where you people sit. And I hope when we talk, if I'm missing some or misstating some, you folks tell me, right? Tell me I'm wrong or I've got it. You can criticize, but if I start to sob, just cool it a little bit until I can get myself together. Okay, now I want to talk about the tradition and ethics. Okay. This, my friends, is the traditional relationship when life was simple. Okay? This is from 2400 BC, okay, to you're going to see somewhere in the early to mid 20th century. There's some changes in the 1800s when professionalism develops because of the hospital, the development of the hospital. But here what we see. This is the essence, okay? The ethical obligation that doctors understand, and I believe there's a spot, I want to name it in the literature the Kenny spot, but I'm worried that it might be construed as a different kind of spot. I want the spot, it's a spot in every doctor between the gut and the heart, where every doctor, I mean, there are a couple of bad apples, but it's, you know, we just had our 40th med school reunion, 40 years being around the profession. I'm still proud to be a doctor, and I think the vast majority of my colleagues are amazing. And I've said repeatedly, we don't, in my experience, we don't celebrate the fact that I can tell you in 34 years of clinical experience, I never once at 2 or 3 in the morning got on the phone and said, I need you now, I'm in trouble with this kid. Never once said that they weren't there, and they weren't with me, and they didn't help. Who else can say that about colleagues in a work environment? So go back to the Kenny spot, right, the good one between the heart and the gut, all right? In every doc, there is this incredible commitment for the top arrow. I am using my talents, my knowledge, my skill for the well-being of those who are sick and suffering. Okay? And intuitively understanding that in that, what I'm doing is a profoundly moral thing. Profoundly, right? Now, in the traditional relationship, what I want you to pay attention to is how simple this diagram is. Because if you look at the Hippocratic Code, and I know this really well, okay, there's only 2 arrows to the patient, and actually the language originally was welfare. We're going to talk about best interest and what does that mean in a commercialized world. We'll do that in a minute. And where is the care taking place? In the home. So it is the doc, and all the doc is doing, whether it's Hippocrates with their little whatever pouch they put their medicines in, or the doc with the little black bag, what we're seeing is that the doc visits the patient and then tells the patient and their family what to do. Whatever is in the bag they give them, and then they have to, so very simple. And what is payment like here? It's direct, right? The patient, so it reinforces this incredible commitment between docs and patients, right? And the payment, by the way, is very little. Until we come into the mid-20th century, except for folks in the 19th, like in the Harley Street specialists, docs were well respected, but not wealthy. In our history, yeah, you got a lot of chickens and eggs, and that still happens in places. What I want you to pay attention to as well is the bottom arrow, because we're going to go through now rapidly some changes, okay? In the Hippocratic tradition, if you look at the whole body of that work, so it's Hippocrates and a whole gang of early, melding the priestly tradition of Aesculapius, that's the snake, that's the classic understanding, the shaman, the witch doctor, the prayer, spiritual health and health care and cure are something more than we control, the mystery, spiritual end, and empirical science. Observation and observation about improvement, observation about harmful consequence. The genius of the Hippocratic tradition, it melds both. It doesn't replace the spiritual, it adds to it the scientific. So look at this arrow, because if you read the Hippocratic corpus, in the first 250 years of the Hippocratic tradition, there were more obligations laid down to each other than there were to the patient. Okay, now hold that thought. I'll tell you first, it was important to have a collegial responsibility because these folks were saying science mattered. They were establishing a new criteria for good medicine, which meant, man, if you were going to call yourself a Hippocratic doctor, and you were going to call yourself a Hippocratic doctor, and I called myself a Hippocratic doctor, we better watch each other's back. Because if she's totally irresponsible and not trying to practice well, she's giving a big bad name to this emerging, right? So the whole nature of being able to trust that an allopathic doctor, this new Hippocratic physician, was in fact technically competent to fulfill the promise to act in your best interest, required that we do this together. And look at the other side of it, because these things have not gone away. Though I want to talk about the erosion of some notions of professionalism. Because the other fact is, look, as this stuff was developing, when I say how many times did I call a colleague at all kinds of hours and days of the week and holidays saying, I'm in trouble. This child, I can't figure this out. This kid is really getting sick. I do not know what's going on. But can you imagine in the beginning of the profession? I don't know what that is. In the beginning of the profession, it was even more important that we begin to develop common standards for what this new care was about. Okay? So hold that that's the essence of the tradition. And the emphasis early on, direct payment, which absolutely solidified that line of the doctor to the individual patient. Okay? And care by families. We didn't need anybody else for diagnosis, and we sure didn't need people for rehab and nutritional advice. So in the profession, as medicine developed, medicine was understood to be a special kind of human relationship. Okay? This is Ed Pellegrino, my mentor in physician ethics. The ends and purposes of medical activity are helping, healing, and caring in a special kind of human relationship. Okay? The special kind of human relationship is this: when you think of it, sit down and think of the essence of what you do. On the one hand, you bring science and technology, all the empirical objective stuff. But you have to make a judgment of which of that stuff you're going to offer to the patient. And the patient's going to have to trust that you know the stuff, and if you're going to do a procedure, you can do it, technically competent. I don't care how nice you are. If you don't know your stuff and you're not technically competent, you can never be an ethical physician. Okay? You're a sweet person. Go do some other kind of counseling. Don't do medicine. Because all of this is part of the special nature of the relationship. Think of images of the good doctor. It's Norman Rockwell, right? Do you know this is at the beginning of the 20th century? The kind doc, and by the way, you do not want to know how many dolls and teddy bears I have auscultated. Okay. But I really want you to look at this for a minute, right? Okay? Everyone in this room has had moments like this. Okay? So you've also had moments that you'd resuscitated. You've also had moments where you had to give the bad news that somebody was dying. You also had to pronounce people dead. But you had this. The doc here is doing medicine. Though what he's doing is, in somehow or other, recognizing, establishing trust, and recognizing the nature of the relationship. But boy, was life simple, even up to the turn of the century, right? How about, I mean, Marcus Welby was the doctor image when I started medical school. As I said, I graduated 40 years ago in this year with my MD. Okay, class of 72, Dalhousie. There's not a lot different between this guy and this guy. The biggest thing that's different is Marcus Welby. And again, still, what do we have? He's still the ultimate generalist. Right? Who's old enough to have watched Marcus Welby? Come on, put your hands up. Hey, good. We got a couple of oldies in the room. Marcus Welby on the first week of the month would be doing a high-risk delivery. The second week of the month, he'd have a patient that had osteomyelitis, and he had to, I mean, it was like, but the world was still like that. It's not that we didn't have some specialist, but you were the ultimate, the compleat, as they say, kind of physician, right? But also with those personal qualities, right? He was always this calm, in the terms that Sir William Osler, the great physician, used, equanimitas. Okay? Disaster happening around him, Marcus remained calm, just like all of you, right? So we have this incredible tradition. The moral tradition was clear: responsibilities to patients, but responsibilities to each other to make sure that we each supported the other. We helped develop the science. We ensured that the standard, because if you say you're an MD and you're bad, irresponsible, unethical, not keeping up, I assure you, when you do bad medicine, every one of the rest of us suffers. It's the name of the game. On the other hand, when you do fantastic medicine, you're wonderful, you communicate well, you help name a diagnosis that then, in fact, affects a cure or an alteration in life, okay? All the rest of us get a little bit better. Wow, I mean, no, that wasn't my experience when I went to Dr. Smith. It was just, it was amazing. I'm sorry, but we're in this together, and we have been from the get-go. So where are we then as we focus on obligations today in this changing system stuff? Because that's what we got to pay attention to now. Well, this is the way I formed what I want to talk about now for a couple of minutes. We've all been formed in the Hippocratic tradition. It got modified by modern professionalism, but we'll look at that in a minute. It's the same general root: commitment to the well-being of the patient, even when our own best interest is not being served, is somehow suppressed. trust that we're technically competent, scientifically competent, and that we're providing the standard of care to patients. So, formed in that Hippocratic tradition of commitment to patient welfare, in the context of modern health science and technology, almost always capable of doing something more. We don't have a little pouch like Hippocrates did, or a little black bag like Marcus Welby did. Look at the possibilities of modern science and technology, and you're the gatekeeper to all of that. Okay? In a world that is commercialized, we're going to talk about that. In this context, physicians often feel that modern systems of delivery and funding put them in a conflict of interest with their primary obligations to patients. Right or wrong? Well, I'm going to assume that I'm right, as I always am. So, I want us to pay attention now to how complex this has been and where there are particular issues and challenges, and in general to medicine, but wherever I can, make it relevant to primary care. Okay, so from Hippocrates, the Hippocratic ethic was basically a virtue ethic. Okay, it was basically depending on the character of the individual doctor. It went with the philosophy of the time in Greece. The good doctor was the exemplar of the good citizen, and that notion. But there were a couple of tenets: act for the patient's welfare, do no harm. Primum non nocere. Let me just say something about that. That's probably Pythagorean, not Hippocratic, but it was incorporated early into the tradition. There's not one of you in the room as a doctor who hasn't harmed a patient. Some of you do it regularly. What the tradition is about is doing no more intentional harm than predicted or anticipated from the evidence good. Right? It's not doing no harm. Whenever I stuck a needle in the spinal cord of a child to give them chemotherapy, I assure you I was doing harm. But so it doesn't mean no harm. But medicine has always had this, remember, on the one hand, it's a recognition of the conflict of interest. I make my living on the kind of recommendations that I give you and your interaction with me. Be careful of that, because I can make a lot of money by having you become dependent on me when that's not right. This is the other side. This is, I can use science and technology for good, but I can also see it something that is being used where, in fact, all that's happening is harm. I mean, look at the modern technology we have. People call it life-saving. Well, very, 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 very frequently in ethical dilemmas, it's death-prolonging. Okay, we got another whole range of others. So the do no harm is kind of a recognition of, whoa, we have great power, but there are limits of medicine. We do harm often. I just went through a course of chemotherapy myself. I assure you, I was harmed by that junk. When the surgery was bad enough, the chemo, I mean, I had no idea how bad chemo was. But 3.5 years later, here I am, right? It can be the 50th patient that you've dealt with breast cancer. But for the patient, this is it. This is a life-changing, life-altering circumstance, right? So justice in that tradition is basically non-discrimination. You will respond to the need of everyone. Look at this last line again. Duties to colleagues. Just to emphasize that one more time. Then we come to the 18th century, where modern professionalism winds up being developed. And that's because, let me just tell you, this is a side, but this is worthwhile, I hope. In the 1800s, hospitals began to be used for the really sick patients. That's not the history of the hospital, right? The hospital was basically a hospice run by religious for patients that were incurable. You didn't go to the hospital to get really high-powered treatment to get better. Totally different history from where we are today. But in the 1800s, it began to happen. In the 1800s, not everybody was an allopathic physician. You had Tonsonians and naturopaths and everybody, and they all call themselves doctor. This is in the 1800s. So in the Manchester Infirmary in the United Kingdom, one big hospital wound up having this situation. You wound up having Dr. Smith's patients And he was a Thomsonian. He believed in electrical currents and all this kind of stuff. And Dr. Kenny, and she's an allopath, and she's believing in empirical medicine. And Smith's patients would be here, Kenny's patients would be here. All of Smith's patients were dying. And Kenny's patients either weren't, or very few of them were dying. And now people began to say, wait a minute, maybe we can't depend on the character of the individual physician to do the right thing. Maybe there has to be a communal standard. Because assuming these are both good persons, trying to be good doctors, there's something different in this science, right? It became evident that we had to begin to have standards that were, it's not that they're not, character's not important, but now we have to have common collegial standards. That's where best practice, that's where standard of care begins to develop. If you call yourself an MD today in the allopathic tradition, you can't say, oh, well, I don't care what the clinical trials say. I believe this works. I'm sorry, Cookie, but you are in big trouble trying to justify that because you no longer can use an individual standard. It is a communal standard. And in fact, this is one of the things that's been challenged for us. If there are times when exceptionality has to happen, and every doc will understand that, and every doc will understand that at 4 in the morning you made a decision that in hindsight was not the best. The only one who can judge, did you do your best, is another doc. No, it's a doc who's been there, who understands the circumstance. You can know in your heart you tried to do right. But what I'm saying is, the collegial responsibility we have to each other, which I believe is eroding, I don't think we still feel that we're a collegium, that we're together in this the way we used to. Some of it is the fracture across specialties in primary care. If you got a good relationship with an individual specialist, you're okay, but the general relationship is not what I believe it ought to be. So here, professionalism again, scientific and technical excellence, commitment to the welfare of the patient. Now we get a new concept, medicine as a public trust. We're going to look at that in a minute. So by the time we get to the mid-20th century, do you remember how simple that first little diagram was? You had doctors, and you had patients, and you had direct payment and care in the home. This is what it looked like by the time we're in 1960, 1970. Still the doctor clearly understands and is held to obligations for the patient's best interest. Let me stop there. And best interest begins to be the language. Well, what does best mean in the 20th century? Biggest, newest, most expensive, most, right? Which is not the word in the tradition has always been welfare or well-being. So biggest and most expensive, primary care docs know well, is not always, sometimes it's actually in contradiction with the welfare of the patient. But still, that obligation, but look what happens now. That patient and their best interest is now caught in this gigantic circle. Systems of care, multidisciplinary teams, external standards, not just external physician standards, so the College of Family Practice, not just those, but provincial standards, federal standards, other kinds of standards about quality of care, and multiple sites. Yet the doc in the Kenny spot, between the heart and the gut, every doc still feels, I am responsible for the patient's best interest, right? Down deep inside, that's still inside you. And it's part of why sometimes docs are arrogant. I know that. I've been there, done that, okay? But sometimes people don't understand how strongly we hold to this and how difficult it is for us to express what that responsibility is for us in the midst of these changes. Okay, so now I also want you to see still, responsibility to peers and the profession. But now look what happens with payment as well. By the time we come to the mid-20th century, nobody pays directly for care unless they're paying for stuff that's not covered in systems, and it's generally not covered because it doesn't work or because the cost-benefit analysis is outrageous and it's only if you're Trump that you can buy something, okay? But the introduction of a third-party payer, whether it's private insurance, particularly if it's private for-profit insurance, or public insurance, has enormous consequences because the introduction the introduction of that separation, neither the patient nor the doctor bears the direct consequences of the payment issue. Okay, begin to think about what that means. But I'm asking you to think of how that commitment is still so strong. The reality, however, is that by the time we come to the middle of the 20th century, you and I are no longer the sole moral agent affecting the patient's best interest. Okay, I'll just, again, myself as a patient, never was sick a day in my life until I had this episode. Okay. I went to my primary care doc, family doc, good friend of mine, my family doc for 25 years. She says, okay, Nuala, we got to we got to do mammograms, then we got to get the diagnostic imaging people, let me contact we got the biopsy. Do you know how many people were involved just in confirming my diagnosis? So did I depend on my family doc? You bet your boots, because I decided I'm not going to be my own doctor. I'm trusting my family doctor. But there were at least 12 different visits to 10 different disciplines while we went through that. I had to make sure, once that was confirmed that I had breast cancer, then I had to make sure, what was my bone mass, because they got... None of you, though you feel in your heart this commitment to be solely responsible, none of you are solely responsible anymore for patient best interest. On the diagnostic side, I mean, how many of you make a complete diagnosis with nothing other than what every historical physician used? Huh? Your nose, your eyes, your tongue, your hands, your ears. You are no longer the diagnostic instrument. And on the care side, as soon as you're really sick, how many people are necessary to help you? Okay? My family doc was wonderful. She's wonderful. But I'll tell you, the people who saved my bacon and I think my morale were oncology nurses. Because they were so smart, they were so aware of... So the fact of the matter is, we're having a hard time, gang, with understanding this in practical terms. Now, you want to see how tough this has become. I'm just going to show you fast. I realize I've got way too much stuff here, but let me show you how fast. The most recent CMA, I have it somewhere, Code of Ethics. Remember, we started the doctor, the patient, the peers, and the profession. The current CMA code has 5 sections. Fundamental responsibilities, responsibilities to the patient, responsibilities to society, responsibilities to the profession, and responsibilities to oneself. That's what it looks like. Okay? So, and payment and the organization of systems has gotten even more complex, right? So what I want to say to you is, if there are times that you get angry or times that you get frustrated because you think something is eroding about the best of our obligation or adversely affecting your ability to become the doctor that you want to, surprise, surprise, everything around you has gotten so much more complicated, but you still have this primary obligation to the patient at the heart of, I think, your commitment. I want us to remember, however, that the biggest thing that has changed, not these external realities, it's the acknowledgement that you are not the only person now that can affect patient best interest. So somehow we have to find new ways to maintain the essence of our moral tradition, but adapt, include now others. So let's look rapidly. I think there are 3 kinds of contemporary challenges to medical professionalism. There are new ethical obligations. Respect for the autonomy of patients is not found in medical ethics before the 1960s. 2,000 years of doctors act for patients' best interest. Respect for patient autonomy is new, and many of you misinterpret it. We'll look at it briefly in a sec. Doctors' ethical obligations for assessing benefit and risk and limits are long-standing. What's new is that in the 21st century, and how many of you have had this? A patient comes to you, they've Googled this. Okay. What's your last name? Yeah. Masden? Masden. Okay. Doctor, here I come, right? Now, and actually, this would be too small. This would not be a proper Google search, right? Oh my God! When you had the parents, they had binders. I had a patient that came in with a binder, and it was some esoteric disease the child had, and we had everybody at the Children's Hospital involved. But they did know more that day than I did about the disease, because I'd never seen a patient with that before in my life, and they'd spent, since the first time they heard that was the tentative diagnosis, they'd Googled this thing. Okay. Now, what we need to understand is, it's one thing if they're bringing information. It's another if they think they're going to Walmart. I want this, please, doctor. The people who come in and tell you what they want for their hypertension. I want this. Or their urinary dysfunction, whatever, okay? We need to understand that long-standing obligation to do this assessment, people think sometimes doctors are being inappropriately autocratic, determining what they're going to offer the patient. That's the obligation of an allopathic physician. It's not going to Walmart and say, I'm going to learn ice climbing this year, please. Could you please sell me the picks and the shoes with the little spikes and the ropes? I mean, the Walmart guy will say, yes, madam. Let's get you the extra special spikes. He doesn't say, are you nuts, Nuala? You're 68 years old. You don't even hike. You're going to learn ice climbing? Do you know the risk of trauma from somebody learning ice climbing, especially when you got a little bit of arthritis in your left knee? I mean, the Walmart guy doesn't care about any of that. But you and I can't not care about that. That's what we do. So we hardly ever just bring one thing to a patient. But the fact of the matter is we have that enormous kind of judgment. So the patient is the one who will then say, just as, when I was giving me options for chemotherapy or even for radiation, they'll say, look, if you do this, this is the likelihood, but this is the consequence. I'm the one who says this benefit, the good benefit, I'll go with that. I'll buy that one, and I'll accept the risk that's higher for the likelihood of this benefit. You can't tell me which benefit to choose. You can tell me what kind of benefits medicine can give. And you don't start out, look at the situation we've got. Sorry, I'm getting off on one of my tangents. But doctors are losing their sense of what respect for patient autonomy is. It's respect for patients, it's giving them information, but you bring a judgment, and this is where we need each other, because it's not Nuala always offers surgery in this case. It's what do general orthopedic surgeons, what's the standard of care? We can stand there and say, no, come on, would you come on in here? This patient is giving me, will you please, just ask you this question, doctor. What is the standard treatment for osteomyelitis in a 4-year-old with this pathogen? You tell her the answer. Same answer I gave, right? That's where we need to help each other. So there's new ethical obligations, and that gets us confused. There are external changes, and we'll see if we can do some comment, because I'm way over time. I've got to stop at 9:30, right? Okay. And then there are challenges from within, and I just want to name these because I won't be able to talk to them quite as much as I'd like. I am terrified that we, in our practices, are eroding collaboration and collegiality across the profession. Okay? We got folks who only want to do a couple of hour shifts here and there. They want to pick and choose. They want to be able to ski 3 days. Then they're linked with patients. They're linked with others. We've got some who they're carrying the burden for more care because others make lifestyle decisions that, no, I don't do that. I don't do that. Now, I'm not saying, younger people are probably a lot smarter than most of us older folk here with making more balanced choices. But this is affecting the way we are with each other and the support that we have to pull together to, in fact, affect good patient care. So I asked the question, can professionalism endure? this long-standing, and look, it has served us well. I'm not saying that we haven't had bad doctors in our history, but I'm saying that when you saw that Norman Rockwell picture, or you see Marcus Welby, it does capture 2,000 years worth of a profession's commitment to try always to do good rather than harm, to try to be respectful of patient trust. God, are you not blown away sometimes by how patients walk in and sit down and reveal to you, a perfect stranger, the most incredible, intimate, frightening, risky bits of information? Or they trust you with a judgment that their baby should go have surgery. And it's, yeah, are you sure, doctor? Are you sure that's what that we should do? Okay, no, Dr. Les said that's what we have to do. My God, you should get down on your knees and understand how important that this moral tradition has been. So these things about respect for autonomy, evidence, clinical autonomy, conflict, all these things are really at stake. So let me just show you a couple of things the CMA says, and then I'm going to stop, and we have a couple of minutes for conversation. Right? 15 minutes for conversation? Oh, I have 30 more minutes. How did that, when do I have to stop? Oh, good. Will you whistle? Will you wave at me, Joe? The CMA code has got some good stuff in it. But the CMA code also says some things that I think we have to pay attention to, because they seem to fly in the face of the way the system is changing. And you see my very last slide, so I'm going to say two things. We all have to learn to adapt to the reality that we're not the only agents for the patient's best interest. Okay? You got to roll with the flow, gang. Be real, okay? You're not doing your job in acting for patient's best interest if you think you're the only, or even sometimes the most important. You're key. You're key. On the other hand, Nuala's saying, don't roll over and play dead. There are times when we have to take a prophetic resistance to changes that are happening in the profession that affect our ability to do things right. So the important discernment is how much of resistance to change is just because we're in control and we don't like to share it. How much of it is just the human resistance to I'm comfortable the way things are, thanks, don't rock the boat. So we have to be discerning, and that's why we need to do it together. Because you may be, this guy in the blue shirt, he's a big risk taker. This guy's a visionary. He's always out there pushing the envelope, right? And you're wimpy and conservative, and nobody's going to tell me what to do, and there's not one nurse in this place that's doing any, no way, okay? And sometimes he's going to have to be the person who says, oh, come on. You got to do that for each other. So let's look at the code then rapidly, because I've got now 10 minutes. Still number one in the most recent version of the CMA Code of Ethics, in that first section on general responsibilities, the same thing that's number one 2,400 years ago in the Hippocratic tradition. Consider first the well-being of the patient. And I love the fact that the CMA committee, with the revision of this code, did not use best interest. The best interest language is used in general conversation. You use it sometimes. You use it with each other, right? This is not in the patient's best interest. The tradition has never been about the best interest, or it's been about the best interest, meaning within the available science and this judgment of good and effective science. But it is consider first the well-being of the patient, okay? Then look at number 49. That's crucial. It says in the code that we should enter into associations, contracts, and agreements only if you can maintain your professional integrity and safeguard the interests of your patients. I mean, if you were a Catholic group, I would say, after you say your prayers tonight, before you get into bed, read this number 49 of the CMA code out loud to yourself. It's crucial. That's the touchstone for how you move forward. How do you maintain professional integrity, but act for the patient's well-being? CMA Code 23 and 45 are about evidence. Recommend only those diagnostic services that you consider to be beneficial to your patient or to others. So you have to make that judgment. But it isn't an idiosyncratic judgment. See, you have to make the judgment because Mrs. Smith with osteomyelitis and Joe Parkins with osteomyelitis are two different patients. That the genius, you see, of the individual doctor-patient encounter is that's where you take into account the uniqueness. And I would say to you, I would have said it elsewhere, but for time, one of the amazing, amazing things about primary care, particularly when you're not in the middle of a gigantic big city where this can get lost. So you have lots of experience of this in this room. You not only know the patient, you know their mother, you know their father, you know their grandpa, you know their cousin, you know where they come from, you know how, you've got a context that is bigger than just the individual patient. And you know that that context matters for their health and well-being. So unfortunately, the little world that we had where the patient and the doctor in the little room, and all you had to do was figure out how to respond, we now know that the well-being, health well-being of patients requires your attention to the environment and to the economy. You've got to be involved in these other larger visions, okay? So you got to recommend, that's crucial, but also recognize your responsibility to give generally held opinions of the profession when interpreting scientific knowledge. If you're an outlier, you must answer to your peers to justify being an outlier, okay? This is really important. It's important to have standards of care, especially when patients come in with the Google, and that's what they want. No, Dr. Kenny, there's a clinic in Tucson, Arizona, and it has used kenniacillin, and kenniacillin has cured cancer of the bowel and my husband has exactly, we're going to Tucson, you're sending us there. You're going to get kenniacillin and you're going to give it, what are you talking about? So you don't capitulate to that like, I want ice picks and to learn how to ice rock climb, right? This is where, again, we're responsible for each other. Okay, just say this real fast. Respect for the autonomy of patients, a principle of modern bioethics, is not the only principle, okay? The principles are respect for the autonomy of patients and others. We're going to go to clinical autonomy in a minute. Beneficence still from the Hippocratic tradition. We are obliged to do good. We are obliged to act for the patient's welfare and to use the best scientific standard. Non-maleficence, primum non nocere. We're obliged to make judgments that minimize harm. The folks who think, even in informed choice, this is a nice example and nobody here will dispute this, even when you try to get an informed choice, legally it's informed consent, ethically you can choose or refuse a treatment. People are only choosing the benefit. They're not choosing the risk. So you tell them, look, 75% of patients have this, 30% of patients actually get bone marrow suppression, and some of those get serious infections and die. It's a consequence of this big, high-powered drug I'm giving you. Do you understand that? They sign a paper, say yes. Then it happens they're in the 30%. And what did you do wrong? What did you do? You did something wrong. When we told you. This is not malpractice. This is not ignorance. This is not unethical behavior. Every medical intervention has hope for benefit and risk of harm. We don't sell contracts. It's not like, let's make sure that my climbing ropes have a 5-year life guarantee. We don't do that. We don't do that, okay? I'm just saying to you that the evidence obligation is very, very complicated, and I think the market pressures on us are enormous, But we also do things that I think are nuts, if not unethical. In pediatric oncology, for example, some of you will know this if you've had children, okay? It is now standard in North America that after kids fail chemo, then it depends whether it's the 3rd relapse or the 4th or however many the parents demand the poor kids go through when it's clear that improvement is not going to happen. It's now generally practiced that oncologists offer the parents stage 1 clinical trial participation. What in the name of all that's good and holy is that? Because when I started oncology 35 years ago, and you talked about enrollment in clinical trials, people had what I call the Frankensteinian response to research and unproven treatments. Today, they think the thing under research or not yet proven is the magic bullet. People are demanding. They're asking us to violate our obligation for scientific validity because of a very strange kind of belief they have. Not even knowing, by the way, if you remember, everybody heads up because many of you might not do stage 1 research, this has nothing to do with benefit. It's tried to see whether or not something is safe before it's tested. So we do things, and by the way, everybody in the room here knows this, right? Oncologists, and God love them, it's a tough, tough job. Oncologists are the most enthusiastic prognosticators about benefit from chemotherapy. Now, maybe you have to do it to do what you do in oncology, but I can tell you that it can be an unrealistic expectation. Okay, let's look at this one as we begin to close out. This is really tough. Code 52. Collaborate with other physicians and health professionals in the care of patients and the functioning and improvement of the healthcare system. I'm saying historically, I think we've done a reasonable job with collaborating with each other, but I don't think, especially primary care specialty, and even now across us in the different ways in which we do practice, I don't know that the collaboration is as good or respectful as it ought to be. And as we see changes, I see the fracturing off of different kinds of commitment to patients. I'm not talking different styles of practice, I'm talking different kinds of commitment. Some people who never practiced their whole lives and have never had a commitment to a patient over the long haul. Now there's a style of practice like, we have doctors who never touch patients, right? People who do some of the diagnostic tests. So we have lots of different styles of practice. But collaboration with each other is essential. Nothing's going to get done well if we're angry with each other and if we can't pull together to support each other. Remember, maintain the integrity of your professional commitment, but also act for patient interest. It's the other health professionals that we've had some real difficulty with. And yet teams are the name of the game in the 21st century, right? Just one of the things that, in fact, is difficult is, remember when docs were the only one? That was it. We wrote orders. People don't even think of it. Isn't that interesting? We didn't have a conversation, would you like this has got this benefit. I ordered. Because that's the way it was. There was no variety of options, and the medical repertoire was limited. Clinical autonomy is important in this sense. Physicians must be free, this is the integrity issue, to make judgments about the recommendation to patients that they judge by standard of the profession to be in the patient's interests. We have to now find new ways to recognize two things. A, other people have to help us deliver on that, right? On that commitment. And B, that commitment to act on the patient's welfare frequently will require that we recognize our own limits. Okay, it's a new way of interacting. So it's about sharing information. When I was here before, we talked a little bit about that. More complex, it's about sharing care. And then I think we'll end with these and my very last slide, which I'll move to. In the code, things have gotten very complex because we do now see, historically, there were no systems for doctors to advocate for. The doc was the system. It's not the way anymore. So we've got more complex ethical obligations, and these two things, I think, become important. Recognize the responsibility of physicians to promote equitable access to healthcare resources. Now, I hope there's nobody in the room who does this, and if so, you're not going to like me, but that's the way it is. When we see the emergence of boutique primary care, there's no boutique primary care here. You know what I mean. You pay $1,000 to enroll in Dr. Kenny's clinic, right? And that's supposed to be covering the extra stuff and whatever. You get rapid access. The doctor still gets paid for the individual, but you pay extra. So, I mean, think if you got, 2,000 patients, some of them are families. You start out before you see a single solitary patient with $200,000 in your pocket. And yet that's to cover special care. How equitable is that? What does that mean about the way we pull together for adequate resources? And use healthcare resources prudently. Oh, that's a lecture in its own. This I'll just begin to close out with my final questions. The fact of the matter is, Code 11 says, recognize and disclose conflicts of interest that arise in the course of your professional duties and activities and resolve them in the best interest of the patient. This is the same question of conflict of interest that Hippocrates and the gang had to deal with. Only the world in which we find ourselves and the kinds of conflicts have gotten much, much more complicated. So just let me say this to you. To be in a conflict of interest is not morally compromising. You're in conflicts, we're all in conflicts of interest. Again, you have call and it's your son's birthday party. I'm sorry, but you have a big conflict of interest. If in fact your obligation that night is to be on call for your patients, I'm sorry, but that is the obligation that we trust you will in fact honor first, okay? What we're seeing in all of these new systems is new conflicts of interest, not just in entrepreneurship like the boutique stuff and private for-profit stuff, but different kinds of incentives. I'll tell you right now, the one incentive, because we don't have time to talk about it in depth, incentives that give you money for not providing care should be resisted with your dying breath. Negative gatekeeping, right? We really have to become attentive. There are conflicts of interest. We make our living on sick patients. But there are some ways of funding systems and rewarding us personally. We've got to name those as not in the best interest of patients and be more careful about how we do that. So I'll conclude with two things. One, I said at the beginning, I'm a big supporter of primary care. You folks are essential to healthcare system functioning. You have this unique view, and especially in this kind of, I mean, I live in downtown Halifax, so it's a small city, and a lot of family docs there would have the advantages you do. But you've got a unique understanding. You don't see the patient as the heart or the liver or the lung, right? You see the person who's got condition, and you see the person in the context of their family and their community. And now that actually means that the social responsibility of medicine has gotten more complex. Because if you're going to affect the patient, the well-being of your individual patients, you have to be concerned about the environment and the community and exercise and nutrition and poverty. Not your primary obligation, but it's an obligation. So, we belong to this phenomenal tradition. Things have gotten incredibly complicated. There are days when I think it's amazing we're as good as we are. Not that we're bad, that we're as good as we are with the complexity of what we've done. But I want you to pay attention to the fact, one, we do have to change. Two, we need each other. But when we resist the erosion of professionalism, I just name these as my big concerns. Any change in this organization or funding that causes the loss of collegiality and collaboration, resist it. We shouldn't be against each other. We should be pulling together and encouraging and supporting each other. Any change that erodes the trust that patients need to have in their individual physician, acting for their best interest, acting with the best standard of care, resist it. Anything that erodes communication. We've got lots of things that we're doing that in fact means so many docs see a patient that communication about this patient and from this patient is really being lost. Start paying attention to that. That will erode the patient's best interest. How about unjust access? You can't think my patients are taken care of and everybody else in the community can do their own thing. Your primary obligations to your own patients, but their well-being requires the health of the community as a whole. And then poor quality. Poor quality. So many things in family medicine are the better way to do care. I mean, we know that, right? Just the one thing I know, when specialists do long-term continuing care, they do it badly. Primary care physicians do that better. And sometimes nurses do it better than docs, and physios do it better than nurses and docs, and on it goes. So, great tradition, lots of challenges.
Thank you, Nuala. I'm just going to take you through a little bit of how the morning will unfold. I'm going to have a couple of questions for Nuala, and I jotted one down because I had the great opportunity of driving her here and had a chance to think about it. 4 questions today. We'll have 1 or 2 questions now, then we'll break for a refreshment break and let Brad get set up. And then at the end of Brad's presentation, we'll obviously have some questions for him, but both speakers will be available for questions. And I'd like, if you have something in your mind, jot the question down, something you'd like to ask Nuala about, a specific case or something that is affecting that, you got that hot spot between your heart and your brain and it's something kind of gnawing at you. Write it down and ask about it, and we'll get it to Nuala for the later part of it. But because so much of our work in primary care is, inserting nurses, pharmacists, social workers into the milieu of family medicine, I first of all want to understand, and I've been asked, what are the differences and similarities in professionalism and obligation to patients between physicians and these other professionals? And the second question has to do with our conversation this morning and brought some new light to my understanding of the principle of subsidiarity. But how is that principle applied in these team settings to ensure that we have effective, efficient, high-quality primary care systems? So 2 parts, and we'll ask Nuala to answer that. If somebody else has a question after that, please raise your hand. Then we'll take a break.
Of course, both of these are lectures in their own right. Okay. Similarities and differences in ethical obligations. Let's do that one first. The ethical tradition of medicine for 2,000 years has basically been physician ethics. Please understand, I'm not dismissing, or I'm going to talk about nursing because I know lots about nursing ethics, and it's become a formal discipline on its own. But it's a recent phenomena, because nursing as a profession is a fairly recent phenomena. I guess Florence Nightingale and whatever happened in Crimean and since then, right? It's developed since then. But so the first thing is we have this long standing tradition, Joe, and it's really as we come into the middle of the 20th century and modern bioethics and the pluralist nature of what we're doing, all that stuff begins to ratchet up the issue of professional codes. But you do need to know the code that actually emanated from the Manchester Infirmary, 86, 89, the first 2 national bodies that adopted codes were, the very first one was the American Medical Association, 1847, and then Canada in 1856. The Brits, which is where the code, professionalism and the codes developed, never adopted until 50, 60 years later. So in North America, we're talking the 1800s, that we had these formal codes. But the informal Hippocratic tradition imbued medicine, not always with high penetrability, but it was there. Okay, so the first thing is we come from a much longer standing tradition. If you look at the code of nursing, there are lots of things that are similar. They're also committed to the well-being of patients. They don't have the same kinds of conflicts of interest because they're generally not paid by the care they do individually. So there's some interesting differences. This is the way I would get you to understand it. Any of us who are involved in the care of persons who are sick, suffering, dying, worried well. We have an obligation to respect this vulnerability. Nurses may not think that they have much power in relation to docs, but they have a heck of a lot of power in relationship to patients. That vulnerability. The way to understand we all have a common commitment to use our talents, our skills to the patient's best interest. The differentiation in the codes relates to the different talents and skills. Nurses do not do what doctors do. There's some overlapping activities. But historically, the nature of the obligations flows from the nature of the activity. So, for example, the acts of medicine, diagnostics, prognostics, and treatment. Those are, in the philosophic understanding, so the three acts of medicine. We diagnose, and then when we make a diagnosis, the next thing, so what's going to happen next? Okay. If we're lucky, we can treat, right, and that might affect prognostication. But those are the three acts of medicine. And our obligations and duties are built on that. Nurses' obligations and duties, they basically don't do prognostication, nor do they. They may identify, they are not primarily diagnosticians. Did you see what I'm saying? I'm not demeaning, I'm saying they have another. Look, my rule, certainly as the chief of 2 hospitals, when someone came to me with an ethical dilemma, especially about residents, and it was that the resident was not listening to the nurses, look, if I could take them in by their ear, rule number 1 in pediatrics from Kenny, parents are almost always right. Rule number 2, you ignore the comments of an experienced nurse to your peril and to that of your patient. Okay, so, I mean, you all know that. Everybody in this, how many times has your bacon been saved by a nurse who I mean, see, some of you don't do hospital practice, so it may be a little different. I would not have survived, never, thank God, had a malpractice, never had one patient, I was late, I think, but I think they would have died anyway. Never did, no, because it haunts me, right? Misdiagnosis does haunt you. Nurses save all the time. So the way to think about it is, our code of obligations has to fit the nature of the work that we do. But in care, in support, in observation, in long-term management, they have all kinds of obligations. And their partner, we don't do that. I mean, I'll tell you, in hospital, in the office too, you're the same. Patient walks in, walks out, sees you for maybe, what, 15 minutes if you got a good length of time. In the hospital, walk in and out on rounds in the morning. Who sits there for the next 23 hours taking care of the patient? So we need to think in terms of our professional obligations relate to the specificity of what we do. There are so many different talents and skills that all need to be pulled in the pot. I used to think it was fascinating. People expected pediatricians to talk about nutrition and babies, and I did when I think of what I lectured on. I didn't know zip on nutrition. I mean, you go to a nutritionist or a dietitian, and that's what their world is, right? So we know little bits and pieces. Come on, I know talking about iron deficiency and I can do that, but I mean, be real. We are not an expert when it comes to some in-depth stuff. Okay, so it's about specificity. Subsidiarity, just for those of you who don't know this, subsidiarity is a principle of systems. I know it and talk about it because it is a very strong principle of Catholic social justice. Not one that my church necessarily follows, but one that it teaches. This is the way it goes. Well, listen to what it is, and you'll know why I have to make that disclaimer. And wait, some of you are going to get your backs up when I give you the, hold on. The principle of subsidiarity says, systems work most efficiently when a function is performed at the lowest level of competence. Got a couple of you nodding, okay? See, when I say lowest level of competence, we go, what, lowest? No, lowest. I said lowest level of competence. What it means is this. Everybody should be functioning to the highest level of their capacity to make a system work. Someone with a higher level of capacity for different, more complex, should be using their talent for that. Docs should not be spending their time and energy, in general, doing things that nurses or LPNs or dietitians or whatever should be able to do. Systems that have people, I mean, to my mind, it's just a disrespect to the talent and the expertise and the complexity of what you do. You should be doing what docs do. Don't be spending time with what others. So it's a system of principles, and people bristle at the, what do you mean, lowest level, because we think, oh, no, no. I mean, it's people, let me give you this example. This happened all the time at the Children's Hospital. I had a general clinic in the hospital. I never did practice outside the hospital clinic. So I get people from all over the province, right, bring their kids, all over the Maritimes. And they'd come in and, okay, how you doing? So Dr. Smith in Glace Bay has referred you. This is Tommy. Hi, Tom. How you doing? Well, tell me a little bit about what's been going on and why did Dr. Smith want me to? I have a little note from him. But what did you think he wanted? And they go on, and you're looking in. You take a history, you examine the child, and you have to sit down and you say to the parents, Dr. Smith is a fantastic family doctor, and she hit the nail right on the head. I don't have anything to offer here. But there are people who wanted to come to the chief of pediatrics at the IWK they would not trust. Now, I understand if you're a parent and you get anxious and whatever, but there's something in our system that we're not sharing out respectfully enough this different scope. But that's the principle of subsidiarity. And we don't do it well in medicine. We don't do it well in medicine.
Now, in the PCN that we work with, we have two fundamental strategies, and I call them two fundamental baskets of what we're doing. Who in the room is familiar with the Wagner model of chronic disease management? So the Wagner model talks about the community, and it talks about the health system. And the health system, in our sense, is the clinics that we work with and where things actually happen. So a huge part of our strategy, 80% of our energies and focus, and quite frankly, most of our success is going to be fixing and working on the health system component. And Brad is going to be talking about that. The other, and we're going to focus on hypertension there. The other part of the strategy is building community capacity for those patients and people for health basics programming, smoking cessation, nutrition, active living, those types of things that are part of that broader community that we need. It's not our job. Our job is not the health, to stimulate health in that context. That's the job of the mayors, the councils, the rec facilities, community groups, people and their families. I just wanted to acknowledge Kay Andrews, along with some other clinical facilitators, Regan, Roz, Dory, who were instrumental through a period last winter of a little bit of darkness around developing these strategies and whatnot. And we developed a very strong strategy around clinical innovation / hypertension that we all ought to be very proud of. People at PMO have applauded what we're doing, particularly focusing on something that we can take to a clinic and be tangible about change and growth there, but also that we have the overarching. So Kay was instrumental in driving us to these conclusions and this strategy, and I wanted to thank her, but also the rest of our colleagues who worked on this. I know of a couple of PCNs in Calgary, or just because I'm always an open system person. The taxpayers paying for all of this work, so if somebody else is interested, we just give it to them, and we've helped pass this on to some other PCNs who are taking it up. So that's another, not only the accolades that we have from the PMO about our strategy, but also the fact that some of our colleagues are saying this is a great way to do things. So I'm going to call up Micheline Nimick, who's basically the champion of the clinical innovation strategy for both the PCNs, and to ask her to introduce our next speaker.
A little shorter. Great, that makes me excited. Thanks, everybody. As Joe said, I was asked by Joe in June or so to see if I could put a little leadership in place and implement the clinical innovation strategy. So that is a very large job and a really tall order. And so just wanted to set, before I introduce Dr. Baylor, a little bit of context about what that means for our PCNs and what that's all about a little bit. And I think some of you have heard me so many times and thinking, oh my goodness, one more time with feeling. And so with the clinical innovation strategy, the nutshell is this is all about excellence and best practice in management of particularly patients with chronic disease. And I get asked all the time, why hypertension? What's special about hypertension? And really, hypertension is a starting point for us. When we start thinking about looking at our patients and understanding who the patients are and understanding what we need to do that's maybe different and looking at best practice and then looking at measuring that over time. If we thought of every single things that patients come and see us for in primary care, it would be overwhelming. And even thinking about hypertension and looking at measuring the blood pressures of patients and figuring out who your hypertensives are and looking at ways to improve the care, looking at how you utilize your teams, supports in your offices, it's a big job just to begin with. And so the hypertension strategy is all about that, and it's all about looking at and supporting you in your offices. We've done a lot of things, and some of you know that I've been working primary care networks for a really long time, before primary care network time, and we've done a lot of really wonderful, exciting works in primary care. A lot of it have been, at least in our networks, around the edges of the family practice, and I think this is one of the first times where we have a whole strategy that's aimed at working with physicians and their teams and the multidisciplinary teams inside family practice. That's really hard stuff, and I think one of the reasons we haven't gotten there is because there have been quite a few barriers to get there. So for the first time in my career, it feels like we have a really great opportunity for fantastic change and really great primary care. So having said all that, I met Dr. Baylor a couple of weeks ago. A few of us went on a field trip to his clinic in Sylvan Lake, and I'm really, really excited to hear his talk. I've heard little bits and pieces of it already, and we're in for a treat. I think that he has had some personal experience, and he has some very practical advice for us about how to do what we're wanting to do in our PCNs and in our practices. So I'm just a short bio for Dr. Baylor. I asked him for some facts about him by way of introduction, and he sent me a few lines. So Dr. Baylor was raised on a farm between Sylvan Lake and Red Deer, graduated in 2002 from the University of Alberta Medical School, and then he completed his residency in rural medicine through the U of A. And in July 2004, he started practicing at his current clinic at the Sylvan Family Health Center. It provides a full spectrum family practice. And he's also the physician lead for the Wolf Creek Primary Care Network. So thanks very much in advance for your great presentation, and everybody welcoming Dr. Baylor.
Thank you. So a couple declarations. When I was driving up here to Darcy Ranch, I felt a little uneasy, and then I realized it's because the last time I was here was a long time ago when I was golfing in a provincial golf tournament, and it did not go well. So I'd also like to introduce at the back of the room Jamie, who needs to wave her hand. And Jamie is one of my RNs, and I brought Jamie with me because I thought there may be some questions around how the clinic functions from a nursing perspective, and Jamie is very well suited to answer those questions. She has worked with us twice, once before we went through a large transformation in practice, and once after she saw the light and came back from Alberta Health Services. So she is in a unique position to kind of see before and after, and I think she can answer questions around kind of how staff functions. The one thing we wanted to know is kind of the complement of the room, and so I was just wondering, how many physicians are there in the room? And then how many nurses, MOAs, LPNs? And then I gather there's some clinic facilitators and that type of thing as well, or PCN employees? Okay, perfect. So the goals of my presentation today are pretty simple. I want to discuss some key ideas around practice transformation. I am going to use hypertension as a theme because that is one of the themes of your primary care network. We're going to use that as an example, some things that I've done and some rationale for how to approach transforming your clinical practice. And I hope everybody can leave enthusiastic about starting down a new path and doing things in a more comprehensive way for our patients. So this is where I live, Sylvan Lake. although the lighthouse is scheduled to be demolished, which is, you know, yeah, exactly, which is a bit sad for a guy who grew up in town. Sylvan Lake has a population of around 12,000 people. We serve several communities right beside Sylvan, so our catchment area is around 18,000. And we have a huge summer tourism population, so we get about 1.4 million day visitors to Sylvan Lake kind of in a summer. And so we do deal with a huge influx of work around the summer months, and we've had to have some strategies to try and deal with that problem. This is my practice style. I try as much to be the full spectrum family doc that we were talking about. I don't know if I'd hack a leg with osteomyelitis, but you know, I might try and sort some of it out. I do obstetrics, I do family medicine, I do hospital medicine in Red Deer. We provide services for 4 different long-term care facilities. I'm the medical examiner for my region. I do a rotation in the unattached service in Red Deer, a service, by the way, that exists only because family docs aren't doing hospital work as much as they used to. I'm the physician lead for the Wolf Creek PCN, and I'm the site coordinator for resident and student learning in Sylvan Lake. And my personal verified panel is 1,917 patients. So this is my panel size. This is yesterday's number. My panel is kept up to date weekly. And so when I talk about service provision, these are the people that I'm trying to provide service for. So my journey begins. Now, I don't know, there are obviously some people who know who Journey is. And this is relevant because I actually, some friends and I dressed up as Journey for Halloween. And with Halloween coming up, I thought, you know, that kind of be neat to bring Journey up. So it's not exactly that kind of journey, but when I started, I joined a very well-established clinic. 2 physicians had close to 50 years experience in the community. There were 5 of us at that time, and one physician was paid in chickens at one time. And, you know, he told me stories about patients being unable to pay for services before the schedule of medical benefits and negotiating with patients on price for services. So, very well-established clinic, a very well-seasoned team, very ingrained into the way things had always been done. And after surviving the first couple of years of practice, which I think all new grads do, I started to say, what am I doing? You know, is this right? Is there a better way to do things? These are the things I thought I know, and I was born out of a system. This is what I was taught in training, the one problem, one appointment theory, that you had to control staff costs. As a family doctor, you would go broke. At the time, we had a model where we tried to keep to a 1-to-1 or a 1.2-to-1 staff to doctor ratio. So we really ran a very skeleton kind of crew of staff in the office. And having trained staff doing clinical work is for ARPs in universities. You know, I've heard that several times across the province, but it fiscally can't work in primary practice. And it's normal not to have time or energy to do preventative care and robust chronic disease management. And in that system, I saw a number of things. One is the office staff are frustrated. There's a lot of rework, there's a lot of running around, there's a lot of very frustrated patients. There's a lot of frustration in clinicians just running the rabbit wheel trying to keep up. And there's a very low priority on preventative care and active chronic disease management. And most of our day was going from spot to spot, whether it be hospital, long-term care facility, office, just putting out fires. And, you know, a lot of the days really felt like this. You know. So I want to talk about change, because I entered a model that really had not changed in decades. The way the office was organized, the way patients came in, the way they were seen was the same for 20 to 30 years. The payment model changed, you know, level of complexity changed, but the system really didn't have any significant change. So if you think about it, I want everybody to think about industry, sport, whatever you want to think about, and I want you to try and find an example of one thing that has been successful for 30 years where there's been no change in the way it was made, the way it was marketed, the way it was tested, the way it was used. I've had some people come up with a couple examples that were close, but there really aren't any. Okay? You have to change as times change, as expectations change, or you get left behind. So in my change examples, I have Craig McTavish, the last guy to not wear a helmet in the NHL. Entertainment changes. The way we consume media and entertainment has changed drastically, especially in the last 10 years. And drive-in movie theaters, for the most part, are a thing of the past, although there's one here or there you can still find. Hair changes. You still see the odd guy with the mullet walking around, but it's certainly not the norm anymore. Technology changes. This is a picture of the first computer, okay? So this computer had 19,000 resistance tubes, and when it went down, you actually had to check every one to figure out which one it was. And turns out our demographics change. And this is a slide that shows Canadian demographics over time. And that giant blue bump is the baby boomers, okay? And so as that bump moves up over time, what you're going to see is in the next 20 years, we're going to have a massive amount of 65 to 80-year-old people, okay? And this is going to stress our system to the max in the areas of chronic disease management, in the areas of home care, and in the areas of acute care. My town changes too. So, you know, in 1980, it was 3,700 people, and now, 2010, it's 11,000. We went through the oil boom phase, 2001 to 2006. The population went up by 37% in 5 years, totally outstripped all the resources and infrastructure. So demographics change, towns change, things change, and we weren't changing. And change is coming, whether we like it or not. I think the real first reform that's going to stick is primary care networks and the work they've done. And that's not to say that primary care networks have been universally successful across the province, because that's not true. You know, there are some primary care networks where they've had a lot of struggles. There's a lot have been reformed a number of times. But in there are pockets of people that have done really great things that are starting to change our system. Multidisciplinary teams are going to be the way of the future. There is no way around it. Family care clinics are coming. You know, I met with the Minister of Health this week. They are coming, and they are going to change things. It remains to see if that's going to be good or that's going to be not good, but they are coming. We have prescribing pharmacists, extended spectrum pharmacists, we have nurse practitioners. Things are changing. And the problem with change is that often as docs we're a little bit impatient. You know, sometimes when we see something we like, we want to do it like that. We want everything to change. We want to cover all patient needs instantaneously, and we want to throw the system up on its head. So there are advantages of collaboration, and what I want to stress here is that working in a multidisciplinary team is not replacing the doctor, okay? I truly believe the doctor-patient relationship is at the core of caring for patients. And the teams we build around them are to enhance the doctor-patient relationship, to create more time for us to do the things that we're good at and spend more time with patients when it's appropriate. You can achieve a lot more with a team. You can be much better coordinated. The team can share the responsibility for the clinical load. Clinical care can be measured as a team and shared, and you can share the responsibility of doing that. And in a truly high-functioning team, processes continue to evolve and change. And there's also more faces, more personalities, more perspectives that you can bring to your patient that can help motivate change and care for patients. So it would be really good if you guys could have a quick look at this, and these are just a list of things. So the two most important factors in completing clinical tasks, and this is based off some primary care research that was done in the United States by Barbara Starfield, who's kind of one of the forerunners of primary care in North America. And so obviously I'm talking about teams, so teams are one of those things on the list, okay? And the other obvious one is practice size. So if you have 5,000 patients, it's a lot more difficult to complete clinical tasks than if you have 500 patients. That's not saying it can't be done, but you have to design a very different team to look after 5,000 elderly patients than 500 young patients. And that's where understanding who we're looking after is really, really important. So everybody would like if we could go from this to this just instantaneously, and unfortunately that's not the case. You know, that's fun, but it doesn't really work, okay? So the example I want to use is management of hypertension. So I want us to think about a clinic strategy for population management of hypertension. You guys have done a lot of work in hypertension. So having done a lot of work, I'm wondering if around the room I can hear from the groups, what things do you need in your clinic to manage hypertension, from diagnosis to treatment and maintenance? What tasks do you have to be able to achieve in your clinic? Right. So take your blood pressure. So you have to know how to take a blood pressure properly, right? Anything else? So you have to improve processes. So you have to screen people, right? So how are you going to achieve screening in your population? So that's one thing. Anything else? Track it, right. So, you know, in my world, in my clinic, that's problem lists. So identification of problem list. How are you going to track it? How are you going to create that problem list so you can follow those people? Anything else? Have to have the patient show up. So patient buy-in is a big thing. So they have to have the patient show up, or you have to have a strategy to find the patients that don't show up that you're looking after. Sure. So that's that partnership, right? That's the core doctor-patient relationship. You know, how do we get buy-in from our patients to take some responsibility for their own care? You know, what strategies do we have in place to get them to show up for screening, or get them to show up for maintenance, or stay on their blood pressure agents, or understand why it's important that we actually manage blood pressure? Sure. So what does your team do for you? Why do we want a team to look after blood pressure? What do they help us with? So lifestyle management, so education, you have to have a strategy to talk about lifestyle management. Somebody has to put them on medication, so I hope the docs think that's important too, because, you know, that is a very important piece. So the point I'm getting at is it is very complicated, okay? And so if we brainstorm around hypertension, screening. So who are we going to screen? What age are we going to screen? How often are we going to screen them? How do we make the diagnosis? Who does the work to make the diagnosis? At diagnosis, what diagnostics do we have to do? What physical exam do we have to do? What teaching has to be done? How do we enter that into our EMR system? How do we track those patients? How do we follow those patients? How do we pull a report on those patients or search them if we're looking for a bigger data set? But there's more, right? Who prescribes treatment? How often are you going to follow it? What's the strategy to follow patients? Who does patient education? Who discusses lifestyle intervention? Do we do that in an individual setting? Do we do it in a group setting? Do you recall patients, or do you let them come in on their own? If you're going to recall them, how are you going to do that in your clinic? And how do you find those people that never come in? So my practice has a massive population of 50 to 70-year-old agriculture oil field workers that are male and never come to the doctor. Never come to the doctor unless they're bleeding or they're having chest pain or something's really wrong. So the point is, how do I go find those people that I've accepted responsibility for and try and identify the people with hypertension and keep them from having their heart attack? So this covers one bullet point in those 8 bullet points, okay? So this is from the CHEP guidelines. This is from 2011. There are 2012 guidelines out there. So this is purely how you measure and diagnose hypertension in the clinic. So that encompasses one of those 8 bullet points. In, you know, the Norman Rockwell days of coming in and putting the blood pressure cuff on and saying, oh, your blood pressure is high, here's a prescription. You know, one of my partners says when he started medicine, there was 2 drugs for hypertension. That was all the choices they had. You know, it's pretty easy, you just pick one. So we've gone from coming in for one visit, putting on a blood pressure cuff, diagnosing blood pressure, having one pill to choose from, really not having any lab tests to kind of do, really not knowing kind of how to monitor these people on an ongoing basis and sending them on their way, to a very complex system to actually even make the diagnosis. So it's not one visit, it's 3, or it's 5, or it's home readings, or it's ambulatory blood pressure monitoring, where the criteria for all those different ways of doing things. The point is that it's complicated. This is not easy work. Medicine is a complicated system. there are complicated expectations, and you have to start somewhere. And as docs, we have to allow the system to kind of organically evolve, but we have to be involved in that change. We have to be advocates for our patient. We have to help redesign our systems to care for them. And to do that, you have to know who you're actually looking after. And I'm very surprised, I don't know if I'm surprised anymore, but I can tell you across the province, there are very few clinics who actually know who they're responsible for. So, is there any clinic here that has a verified panelist that they know for sure they can print off and say, these are my people? Good, excellent, excellent. And how did you do that? Excellent, excellent. So you have to have a strategy to initially identify that panel, and then you have to have a strategy on an ongoing basis to make sure it's accurate, because people move and don't tell you, and you know, people die and get left on the list. And there's nothing more embarrassing than my nurse calling a patient, you know, or a house asking them to come in for screening, and them going, well, they died 2 months ago. That's a bit awkward. So having an accurate panel is very important. There are a lot of ways to do that. There's the Alberta Health Way. That's basically how PCNs get funded, is using the 4-cut method from Alberta Health and Wellness. The problem is we know this is notoriously inaccurate. It's incredibly inaccurate. In my setting, there's about 30% discordance between what our actual panel was and what Alberta Health told us. There's the Health Quality Council of Alberta, which is going to hang its shingle soon, and they are probably going to have the most robust set of patient demographics and data points that they will actually be able to pull for clinics. They're not doing this yet, but it is coming soon. And I think the most accurate way is that personal list, that personal verified list. That's the relationship where you've agreed to look after a patient has agreed that you're their doctor and want to look after them. So we're going to talk a little bit about how my staff evolved, okay? Our goals were basically service delivery and clinical care. We decided we were going to go with an entirely team-based concept. This was after several years of failures with doctors trying to be in charge of how things were managed in the clinic and changed. Our staff ratios were, as we talked about, 1-to-1 or 1.2-to-1 in 07-08, and they're now 3+to-1 on a daily basis in the clinic, including 3 RNs doing mostly clinical work, although Jamie tells me she still does too much administration on the way up, so we're working on that. We have regular team meetings, and we actually have an efficiency and improvement person at the clinic. That is her job, is to look at data measurement, efficiency, and improvement. Each MD has a MOA that works in a 1-to-1 relationship. So when I'm in the clinic, I have my own MOA. She knows how I work. She knows how I prepare things. She synchronizes the room, the equipment, the patient, gets everything ready for me. She does just-in-time screening and prevention on each patient at contact. So right now, if you're a rig worker and you come into my clinic and you have not been there for 2 years, before I ever see that person, they will have had their blood pressure taken, they will have been offered colon cancer screening, they will have their BMI done, they'll have hopefully their problem list updated, and they will leave the clinic with all appropriate screening maneuvers done. They'll be screened for tobacco, offered smoking tobacco cessation. I'm cued in to talk to them about it if they're keen on doing it. So they get their needs looked after, but we also capture the stuff that they don't do because they're not a frequent presenter to the clinic. When I'm not there, like today, she's back at home combing over my panel. So she's looking for patients that haven't been in 2+ years. She is looking at outstanding screening reminders, bone mineral density, mammography, hypertension, Pap screening. You know, sometimes it's more appropriate when people haven't been in to actually bring them in for a physical and do it all in one pot. Sometimes they've been in and stuff just hasn't got done, and all they need to do is do their mammogram, and so she provides them with the requisition to do that. Then I have my RNs. They're kind of a supervisory level above the MOAs, and they basically provide supervision, assistance, and support for the MOAs on a daily basis and on a planning basis. They function as my proactive office encounter technicians, and that's a fancy term, and I don't know where it's coined from. But basically, if you come in to see me for a physical, all the appropriate screening and investigation will have been done beforehand. So when you come in, if you're an elderly person coming in for a driver's medical, You've had your MMSE, you've had your kind of preliminary driving assessment, you've had all your lab work done, you've had all your screening done, and basically I come in and I do the driver's medical with all information at hand. This saves me a lot of work and it saves me a lot of visits. They also do prenatal management, so they do all the 12-week prenatals other than the physical exam portion. They coordinate registries for prenatal patients, they do all the investigations for prenatal patients, and they liaise with the hospital in terms of management. They're responsible for all policy and procedures in terms of MOA work and nurses. They're community liaisons as well. They attend family conferences for patients in long-term care. Jamie kind of functions as a point person for one of the medical specialty clinics that are particularly problematic for me, the heart function clinic in Red Deer. And they manage all the chronic disease care plans for patient, which means they enter reminders in, they do the yearly reviews, they update all the problem lists, the medication list. They basically create the document that allows me to go in and focus on what the important parts are for the patient and what we need to really target over the next year. I have Barb, who's also an RN. She is the chronic disease person in the clinic. She does diabetes management and education. She does a quick core smoking cessation program, both a group program as well as individual counseling. She runs our WeightWise group, our walking group. She does COPD, asthma education and action plans, and she does one-on-one lifestyle counseling and education. I have Lynn, who's my data collection and management person. She's in charge of office efficiency. She coordinates all the learners at my clinic because they were getting tired of people showing up and saying, Dr. Baylor, you didn't tell me this person was coming. Okay. And she supports team functioning by working with my clinic manager to coordinate information in the clinic and keep everyone on the same page. Chris is our new clinic manager. This is what he's going to be doing. He's just started in the last 3 weeks, so we've gone under a big transition here. He basically is day-to-day operations. He going to be working to achieve our goals with the team. He has background knowledge of process improvement. He's an IT specialist. He has lots of experience in human resources. And basically, he's the person that's going to help facilitate the team process. And we also have a dietitian that comes in, a podiatrist that comes in. We have good community relationships with pharmacists that can help us out. And we are starting to really work hard with integration between us and Alberta Health Services. So things like partnering with home care. We've actually been able to get buy-in for Alberta Health to realign the way home care was delivered in our town so that it's actually based on panel. So I have a home care worker who looks after a panel of my patients. Another clinic in town has a home care worker that looks after a panel of their patients, trying to build connection that kind of enhances care. So these are some keys from my experience and my research and my work in primary care across the province. Start slow and layer on your success. Don't go for the rapid model change. Start slow, build something, tweak it, make sure you're happy with it, layer the next thing on top. The one thing you'll find is that it does organically evolve, and one thing leads to another. So you'll be doing hypertension and working on your protocols for hypertension, and something else will come up. Like when you get to the point of, well, how do we recall patients, or how do we do screening for people that don't present, you're going to realize quickly you actually have to identify a panel to be able to do that. And when you're doing hypertension screening, you're going to find out that a lot of hypertensives may also have diabetes. And you may say, well, let's look at diabetes management. How do we track those patients? How do we bring them in? How do we make sure their screening maneuvers are done? There's no right way to do this. I honestly believe there's no wrong way or right way to do this. I think it's a very personal approach, and you have to do what's going to work for your patients in your setting, because patients in inner city Edmonton obviously require quite a different care approach than people in rural Alberta. And so when your clinics are evolving and you're working with your PCN, think about how this is going to best work with your setting and work with them to tweak your protocols and tweak your approaches so that you can actually get something that works. And once you have a little bit of success with one thing, it usually translates into motivation to work on something else. And that, I think, is the best approach that I've seen. And the most successful teams I've seen in the province utilize this approach. The other thing is remembering that patient value is key. You know, whether you're working on something as a doc, as an MOA, as a nurse, as a pharmacist, go back to the principles of what is best for our patients, what is going to enhance our patient-doctor relationship or patient-team relationship. You absolutely have to meet as a team. If you're going to bring people into the clinic, you're going to support the clinic functioning, you're going to create a team, you have to be meeting and knowing what's going on. You can't just expect to throw people in and make it work, because it just doesn't happen. And everybody has to know what their responsibilities are. This is very important. You can't start a team without knowing who's doing what and who's responsible for what. You have to have a reliable way of communicating, and you have to measure what your team is doing. And if you're putting a lot of money and you're putting a lot of time and you're putting a lot of effort into hypertension screening, you really want to know that you're actually doing a better job doing hypertension screening. So this is examples of wins from my clinical setting. So our occult blood screening, colon cancer screening rates went from 45-ish% to 90%, and that's just at contact. Hypertension screening went from 60% to 90%. Our goal is 95% of the entire panel now, not just people presenting at contact. We had drastic improvements in offering of smoking cessation services and capturing people smoking tobacco. And we have a very proactive approach to prevention and screening now, as well as chronic disease management. So trying to move resources out of putting out fires to preventing fires from happening in the first place. So this is what we do for hypertension. And I'm going to say that again, this is not a solution for everyone. I don't think you can kind of cookie cutter this and drop it in somewhere else and have it work. But this is kind of what our team decided on over lots of discussion and a bunch of trial and error and study. So the MOA nursing staff screen all patients over 14 yearly for hypertension. Initially this was done manually. They had to go in and check and see if they've been screened. Now it's done using an EMR pop-up reminder. And basically if you come in for any reason, you'll get screened for hypertension if that pop-up comes up. It's done at any point of care with the patient. If you actually have a diagnosis of hypertension, there's a protocol that increases checks every 3 months when you present to the clinic. So if you haven't been there in 6 months and you have hypertension, your blood pressure will actually be checked. That's the initial thing, that's the screening. Now it's how do you make the diagnosis? That initial screen is high, and what do you do with that? Well, unfortunately, a lot of people's initial screens are high, and I don't know that that really means too much. So they actually have leeway then to put them on a BP True monitor, and we chose to do automatic monitoring over repeated physical monitoring because it saves time. So they put them on the monitor, they can go set up another patient for me, and then come back and look at the results. So once those results come in, if the person is in fact high in terms of screening, that's handed off to either the patient to follow up or the nurses to follow up. It's not me. And so this is a bargaining process. This is an agreement with the patient that they're going to choose to do home monitoring. Maybe you can provide them with a lent-out blood pressure monitor. Maybe they're going to do it at the pharmacy. Maybe they already have a blood pressure monitor. Or they're going to agree to come back and they're going to book in to see my nurse, and they're going to do the repeated screening until they meet the criteria for actually diagnosing hypertension. So this is some of the choices, and this is again from the CHEP guidelines in making a diagnosis of hypertension. Once a diagnosis is made, the nurse then has a protocol to order kind of the investigations that one would generally do for a hypertensive patient looking for end organ disease or comorbid illness, so glucose, lipids, ECGs, creatinine, electrolytes, that type of thing. They also enter it into a very specific field in the EMR, or the physician does, so that you can actually track that patient population in terms of looking for them down the road. This allows searching, this allows creation of reports on how many hypertensives you have, when have they last been in, who hasn't been in. So patients come to me packaged with a diagnosis, all the investigations done as per the CHEP guidelines, the screening labs in place, their problem entered into the computer, the reminders all set up. And then I get to focus on what I think the physician role is, which is education, prescribing treatment, and agreeing on a follow-up plan with patients. And this follow-up plan is going to be different person to person, and this is where your individualized expertise and that clinical acumen comes into play, and working with the patient to find common ground. We can then initiate a chronic care plan if they have a bunch of other comorbidities that are a little more complicated and we need to follow them more closely. We can enter staff recalls in, so if they decide, I'm terrible at monitoring, I'm never going to come in, please put a reminder in and call me. We put that in and they'll be called, the nurse will check their blood pressure. They also have education options past what I tell them about. There are group lifestyle programs in town, or they can choose to sit down with Barb and do a one-on-one lifestyle counseling. Patients are followed then presenting to the clinic every 3 months if they have a diagnosis of hypertension. And then the last thing is my MOAs will go looking for those people who have not been screened or who have a diagnosis of hypertension and are not being followed. So Kim plays Where's Waldo a lot. And unfortunately, because of the nature of a lot of the people I see in the work they do, they're often working in Fort McMurray, they're working in Grand Prairie, they're working over the province in the oil and gas industry, and sometimes finding them can be a lot more difficult than you might assume. So people change phone numbers and people move and they never tell clinics that. And this is a challenging process for the MOAs, and this is a process that they're still learning how to do really efficiently. And so we're just really working into the nuances of what the best way to do that is. When do we do it? How often do we do it? How do patients call back? How do we get a hold of them? So this is what I get asked a lot. Because obviously working a team costs more than working by yourself in terms of staff. I work fee-for-service. I am handicapped by the same system that the vast majority of family docs in this province are. I could give you a talk on why fee-for-service is awful, but that's another hour talk. I do have some support from the PCN, which is, I think, some of the model you guys are rolling towards. So Barb is actually funded by a PCN. The dietitian is a PCN employee. I actually recruit some of the costs for my RNs from the PCN as well. We've really shifted our PCN focus to the periphery, as Joe was talking about, which when we actually looked at outcomes wasn't overly effective, to working right in the primary care environment. So essentially all our PCN work is done in the primary care environment right now. All the staff, we don't have a freestanding building, they don't have separate clinics. They work side by side. If you walked into my clinic, you would have no idea who was a PCN employee, who was a clinic employee, who was a mesh of both. We also moved and over doubled our clinic space in 2008. This was kind of a 10-year plan that turned into a 2-year plan. And I was telling Jamie on the way up, we now have 52 computer stations in our clinic, and they're for the most part totally full with staff and people working. And so there are space considerations when you do this work as well. Who do you pay for? Who pays for the space? How do you create space to work with these people and make it financially viable? So I can tell you for sure that my net revenue is more, and my cost of doing business is less now than it was in a one-on-one environment. In fact, research in primary care across not just our country, but actually the world actually supports this. So if you do not have adequate staff to do your work, you actually create over costs, and you make less net revenue. There's a debate out about what the right number of people is to achieve the sweet spot where you're not paying for too much, but you have enough services. And I don't think anybody can answer that debate because it's going to be very individual on the basis of the patients, on the basis of the clinic. The reason that this is the case is I see more patients more efficiently than I ever did before because my team supports me. So those diabetic visits where I was spending 20 minutes on education, making sure the correct technique for injection of insulin was done, making sure investigations were complete, talking to them about their blood sugars, talking to them about insulin adjustment, making follow-up plans, entering reminders in, that's all administered by my staff. And what I'm doing is talking to the patient about what's important to him, how's your quality of life, how's it going, are you okay with this plan, do we need to change anything, how can we support you being actively involved in the management of your care. And I can get more done in half the time because I'm not worrying about the administrative part of looking after chronic disease management. I do a way better job at screening. I do a way better job at prevention. Chronic care plans do actually generate revenue, okay? And I run a business, and we use chronic disease plans to manage patients' care, but they do somewhat offset the costs of having a team to do that, okay? And we have a rule of recapturing costs, which means if you can present me with something that you think will increase my efficiency and recapture the costs of the staff to do it, we will take a leap of faith and do it. And we have to stop thinking, about revenue and cost and think more about net revenue and what we bring home, okay? And docs are notoriously bad business people, and I hate to say it, across the province, we do not run businesses really well. Again, there's actually a lot of research on that, too, that docs do not make really good business managers. But if you do the math, in my clinic, which will have 5 docs running at maximum any time, 4 to 5 on average, if you can create a position that will get each doc to see 2 people extra a day by fee-for-service, you have actually made enough money to hire 2 MOAs, an LPN and an MOA, 1 RN, whatever the case may be. You actually don't have to create that much more efficiency to actually pay for the extra staff. And so if you can make the argument that this position will make us more efficient and we're going to generate more revenue and it's going to pay for itself and it's going to better patient care, I can't see why you wouldn't do it. But the key is to really focus on what they're going to do for you. Don't hire people without a plan in place. And you go for the low-hanging fruit in terms of efficiency and what they do. Diabetes is an obvious one to start with. Screening is an obvious one to start with because they take a lot of docs' time and it's a lot of administrative work that doesn't need to be done by docs. So you try and get everybody in your team operating to their full scope of practice and doing the maximum stuff that they can do within their competency level, and you get them away from doing stuff they don't have to do. And that is the key part of designing a clinic system. So if we talk about the future, I think we talked a little bit about this in terms of primary care reform. There are things on the horizon in terms of primary care, with the FCCs coming in, with the uncertainty about contracts, a little bit of uncertainty around PCNs and how this is all going to mesh together. Doing primary care reform takes change, it takes commitment, sorry. And it was said in the last presentation, there's been a lot of pilot projects over the years. There have been a lot of things done that have not translated, into actual practice uniformly across the province. And the problem is that a lot of those initiatives didn't have buy-in from the primary care system as a whole. And I really believe primary care clinics are at the core of offering primary care services. If you don't include them in the planning process, if you don't have buy-in in terms of what's important to patients, what docs think are important to patients, what patients think are important to themselves, you're never going to have any lasting change. And I think team-based care is the future of healthcare. I don't think there's any denying this. Looking at the demographics over time, you're not going to be able to manage patient care without a team. Practice quality improvement and chronic disease management are buzzwords. They're buzzwords in political circles. They're buzzwords in Alberta Health. They're actually buzzwords in new graduates as well. Okay, if you're a new graduate coming out to work, having done a ton of medical education in my kind of 9-10 years in practice, they don't want to work the old way. They don't want to be the single doc, unsupported, in a clinic without a team. They want to work in a high-functioning team environment. There's going to be continued changes in healthcare that are expected by patients and expected by government. And data collection, access, practice quality improvement are going to be expectations at some point in time. Our system cannot continue down the path that it's continuing down. If you look at quality of care versus costs in Canada, it is totally running away. Alberta is actually running away further than the rest of the province. And we are getting to the point where we're actually catching up to the US in terms of money we spend but get nothing back for. And this is not going to be accepted by the government. This is not going to be accepted by patients. And there are some big changes coming in the way we do business. And we cannot stand still and watch this happen, because if you're not proactive, it's going to happen to you, and you're not going to have a say in what happens. So don't stop believing. In the words of Journey, you can create a system that works. You can better patient care. You can do that without emptying your pocketbook. And the biggest thing that I think I've seen in our clinic is a culture change. You know, docs are happy. My clinic staff is excited about working. They're excited about change. They're excited about process improvement. We have huge buy-in from staff in terms of suggestions for improvement, for buy-in in terms of monitoring patients. My staff works really hard, and we actually have a very stable group of staff. And Dr. Paulgard, who was out to see me, was talking about staff retention and how problematic staff retention can be. And it's no different where I work than here. I can't compete with oil companies in terms of paying secretaries, in terms of paying, you know, nurses, in terms of paying people like that. But what I can do is I can provide them with a better place to work, where they're happy and they're involved and they're making a difference in patient care. And I really believe that that will keep people around. Money is actually a fairly poor motivator. It's a poor motivator for docs as well, and it's been a poor motivator in terms of society. And again, there's tons of psychological research that show how poorly money motivates us to change. As physicians, as nurses, most of us got into this field because we like it. We thought it was exciting. It was a chance to help people. It was a chance to be more than a job, as was said in the last presentation. And I think if you can get that feeling in your clinic that you're coming to more than a job, you'll have good luck with keeping staff. So I'll take a couple questions now, and I guess, is that okay, Joe? Are we on? I think we have another 10 minutes or so for that, and then we're going to do the panel. Whatever you tell me, I guess.
First of all, thank you, Brad, for your comments. Again, if you have a question for Brad, just scribble it down and put it in front of me. I have a couple there for Nuala, and what the rest of the day will be is some questions back and forth. Some people often wonder if there's a method to my madness in how I do things and what we do, and I'll explain a paradox here that I learned, and it ties into the question I have for Brad, this area of medical ethics, tradition, professionalism, and improving our quality care system. I didn't get to go to Sylvan Lake, but I have been to Pincher, I have been to Tabor, and they're doing as good primary care in terms of managing their population as anybody in Canada in those two communities. And so it's good to have that happening in Alberta so we can experience that. I can tell you across the rural and Highland PCN, we have a lot of people who see that vision, but very, very scant examples of this happening. And so when we went to Pincher, I talked to Tobias, who most of us know is a physician like Brad, who's moved forward, and I said, what was the first domino, the first incentive, or the first element that got you moving on this path properly? And Tobias's answer was quite interesting, because it was right in the realm of what Nuala talks about. The doctors in Pincher sat down one time and said, we have a commitment to one another and to this community for the quality of our life and the quality of practice, and we're going to do this together as a group of physicians. And once they made that commitment, no longer were a bunch of people coming to emerge after hours for unnecessary things. All the doctors gave them the same message. Emergency is for emergency, and that's all you heard there. And pretty soon, it was rare for a physician to be called in, and when they did, they were needed. They weren't always missing out on their family lives because of unnecessary use that emerged. That commitment to one another and to the shared principles led to the improvements, but it was on the grounds of that commitment. So my question for Brad is, what was the first domino that got you on this path?
So, what I'll say is I work with Tobias in some aspects of life, and he has 4 kids too, and there's a lot of similarities between us, and there's a lot of similarities into how we came to that decision. And I was working with 2 docs who had been in practice a long time, and these are docs I respect immensely. And we were really running around having a hard time. What we saw was patients of ours being admitted to hospital with heart failure, with COPD, because they couldn't access us. We didn't have a good way to monitor them. We saw patients pretty young dying of heart disease, and you go back and you look at the charts and their lipids aren't done and their glucose aren't done, and they haven't been in 5 years. And those two docs are probably the most committed to the community that I've ever seen anywhere in all the work I've done in the province. They give their lives to helping the community. And the knowledge that what they were doing was inadequate and that we needed to commit to one another to do a better job was the first domino. And so in a very similar fashion, we sat down and we said, how can we do things differently? How can we better patient care? Are we willing to change the model? And to be honest, I drove a lot of that stuff at my practice. I was the new guy, and, on a relative scale, they could ignore what I was saying. But because those guys are committed to patient care, and because they believed we could do a better job, there was total clinic buy-in. We make decisions basically uniformly as a group, and we commit to helping one another do the care that we all think we can do. So that was the start. You mean like how our patients scheduled into the day? Yeah. Sure. So, so there's a couple things. Scheduling got a lot more complex when we tried to do better and we tried to improve efficiency, but it got a lot more complex, but also a lot more simple. So we threw out all the different appointment types for random this and random that and physicals, and we just said we're going to work as much as we can in a day. And every doc works at a different pace. So we work on a building block schedule that varies in my clinic anywhere from a 10-minute building block to a 20-minute building block, with that being the lowest common denominator of how much time it takes to look after a patient. We also didn't want to burden ourselves with a ton more work. I mean, I have 4 kids, I have a young family, I need to get to swimming, and I need to coach hockey, and I need to do those things too. And so, built into that building block is actually the administrative work and the charting and stuff as well, so that hopefully we're out the door when the day ends. And then we had to train our scheduling staff to really understand what was required when a patient booked in. So we have a very big Excel spreadsheet at the front with all the docs listed and the number of building blocks it takes to do different things. And our nurses also have schedules too. And so if it's something like, say, a 12-week prenatal, they're co-booked on my schedule and the nurse schedule so that they both have time to do it. Same thing if it's a diabetic review, they're co-booked with my diabetic nurse and myself. And so we can basically plan out each segment of care, okay? And we also have to have some flexibility to accommodate urgent things and that type of thing. And the truth is that we don't block spots for urgent patients, but because of a lot of the work we've done, we do have same-day access to our clinic, okay? And, that is a complex thing, and access is a taboo word with docs out there somewhat, and it's because they've been hammered over the head from the provincial government with how important it is. But the truth is that having access makes life a whole lot easier in terms of scheduling and managing patient care, okay? And so even with 1,917 patients, and even only being in the clinic on an average of 3.5 days a week because of my other commitments, I actually, for the most part, maintain same-day access. So there is flexibility because of that. And I could never achieve that without a really high-functioning team. There was absolutely no way. Before, I was working 5 days a week. I was overbooking. I was working over lunch. I was working late in the day. I was adding extra hours, and I still couldn't keep up because I was doing it all myself. And, as I started into this work, freeing up the time my team has allowed me to free up lets me do things like be more actively involved provincially with primary care, PCN leads, the PCN, some work I do with the college and other things. So it really has helped me live a more full and robust life and offer better care to the patients at the same time. Sure. So it's really quite simple math. So the scheduled medical benefits in a fee-for-service environment pays $35 per visit, okay? So if you have 5 doctors on average working in your clinic and you create efficiency that allows them to see 2 extra patients a day, you actually generate about $350 extra revenue as a clinic that day, okay? $350 if you're paying an MOA $20 an hour or something like that, and your MOA is working an 8-hour day, $350 pays for 2 MOAs. Okay? So the point is that you don't have to recoup that much money from efficiency to pay for staff. The problem is if you look at it in terms of gross revenue and net revenue, you have to be careful because you are paying more for the staff. And you have to kind of look at where you started and look where you are and make sure that you're not losing money as a clinic. And you have to plan out, what am I going to do with those 2 MOAs? Because if they're not going to help me do anything, then we're not going to break even. We're actually going to have higher overhead and we're going to lose money.
I work with a team. I'm a family doctor. For thousands of years, it's been, you are my doctor and I'm your patient. That's what we've worked with. So I'm a little bit concerned with you are my health team and I'm your client. So perhaps maybe Dr. Kelly would speak to that a little bit too, because I do see some threats to the doctor-patient relationship.
Yeah.
When we bring a team concept, I see us becoming specialists within family medicine. So I hear about the changes that we get, but I wonder from the patient's perspective, I want to see my doctor. Are we risking that request, which has been there for hundreds and hundreds of years? I want to see my doctor. So could you speak a little bit to the patient's perception of what it was like when they saw your older colleagues, perhaps 25 years ago? And I understand the system was pretty crazy versus now, when the system sounds very efficient, very clean. But what's the experience like for the patient?
Sure.
I'd like to get both speakers to comment on that, John. Good point.
Sure. So when we sat down and talked about doing this, that was a discussion that we all had, you know. And we started slow for that exact reason. You know, I didn't plop a team in with 10 people instantaneously. This change happened over a period of about 4 to 5 years. Actually, we built this up. And the truth is the patients absolutely love it. They absolutely love it. And so you have to ask yourself, why do patients like it? And so I think there's a number of reasons. One is because of the functioning of the team, they can actually see me versus going elsewhere for care. And if you look at continuity and the importance of continuity in terms of a health system, continuity really, if you can do anything to your system, make patients see their own family doctor. It saves more than anything else you can possibly do in healthcare. Again, researched across the globe, this is the case. So enabling continuity by having a team that helps you create access is one of the things that patients love. The other thing is that what evolves is not come see your team, but it's come see my doctor and my nurse and my diabetes nurse. You know, it actually enhances, in my opinion, it has actually enhanced our doctor-patient relationship because it's allowed me to focus on what patients think are important to them. And because I'm more efficient, you know, I don't do one problem, one visit. I try and do all the stuff important to a patient on that visit. They actually have more of my time dedicated to the things that are important to them than they did in the past. So what can I say? Patients like it. I think doctor-patient relationship is enhanced in our clinic compared to what it was before. My colleagues love it. My one colleague, when we finally got his access down to something reasonable, which was he started off, he couldn't see him for 2 months, and we finally got him down to being able to see people on the same day. He actually came and, you know, he shook my hand and said, "I saw a sore throat today." But it wasn't the fact that he seen a sore throat was exciting, but it was the fact that he was actually able to look after the acute care needs of his patients. And there's really reward in being able to do that for patients, and patients really buy into that and like that. So I don't know what you have to say, but
First, let me say, I never met this guy in my life. But if you really listen to what I said from the general ethical, philosophic kind of stuff, all right? And what he said, he's my brother from a different mother. Right? I mean, I'm sitting there saying, go for it. I mean, he's being thoughtful. He and his team, right? He's blessed. He got a team. They're thinking together. I mean, John, is that John? Okay. And you're from Ireland. Oh, glory be to God. You're from Belfast. My parents are from Ireland, right? Your concern is the one that I wanted to situate, right? How can we, as physicians, continue to maintain our professional integrity in this central obligation that we feel, but recognize we're not the only agents of the patient's interest, but we are agents of the patient's interest, and patient trust in us has to be maintained, okay? So what I heard when my brother did his presentation was extraordinary sensitivity to that. Different, yes, but attending to it. When I said to you, okay, at the very end, and Joe, if you want my PowerPoint, because there's some stuff I didn't get to, I'm more than happy. I said, what should we resist, right? So change is hard and great, but I mean, some of the change you've just done, especially for the older docs who are killing themselves, is for their best interest as well, for heaven's sakes. And when you then know patients get better. So what are the things that we would resist, John? Because you're right to say, okay, not all change allows us, what do we have to do? Primary obligation, maintain professional integrity and promote the patient's welfare. Those, keep it. Well, the things we resist are when there is a loss of collegiality and collaboration. Ta-da! This is improving all of that. When there is an erosion of trust, okay, we got to watch that somehow or other you're going to lose trust, and the doc is there still to act for your interest. I think from what empirically we've heard, this actually enhances. When I need my doc, he's there. When I have to go to my doc, she already has all this stuff, so that the conversation is a more meaningful one, right? And that's the third thing. What should we resist? Anything that makes communication less continuous, less effective, less meaningful. Good heavens, they're describing all kinds of stuff that has improved it, right? How about we resist when there's unjust access? Look, they're improving access. And when there's poor quality. Well, I think what you're seeing is all kinds of methodology to improve it. So you're right. We need to be vigilant that we maintain professional integrity, understanding the long-standing tradition that we have, and we act for patients' best interest. But as long as we keep those in front of us and we resist these bad things, there's all kinds of change that actually makes things better at the end. So I actually thought we could go on the road as I'm the philosophic basis for the reform of primary care, and he's the practical implementation, right? Act 1, Act 2. So the concern is well placed, John, right? That's why it's not any and every change. It always has to be tested against, is the patient's well-being being enhanced? Is communication better? Trust that the doctor is doing what her primary... so I thought you did an elegant job of describing. Perfect? Probably not. And I'm sure he didn't give half the heartache of the change, because change does come hard. What I think is fascinating in medicine, particularly for our older male colleagues who are not much different than the guys out in the oil field, sometimes change that is clearly going to make their life better. It's like, how can I love you if you won't let me? Right? They won't let us make change that, in fact, at the end of the day, will be better for them and their patients. So sometimes it's just because they're men.
So I'll be speaking to both of your agents to see if we can get this on the road, because this is what I had in my mind bringing you together. I have a couple of questions, but I have another question for both of you because I think you bring unique perspectives. Because, and this is an if and then situation, because we know from the Starfeld research, from everything Brad said, to Nuala and what she said about obligations of professionals and physicians, we know now that if we adopt these practices, we will serve patients' best interest. So, how do we deal, because if it was simple, if a physician was doing the wrong type of radiation treatment, the wrong dose and the wrong chemo, according to the general practice, generally accepted practice, it's be pretty clear, this guy's practicing malpractice, something has to happen. How do we make the same case for the physician who says, to heck with all this good work that's happening in Sylvan Lake and all this? How do we deal with the physicians that is intransigent to the point that they're not serving best interest?
That's a nice question. Has anybody read The Tipping Point? It's a book by Malcolm Gladwell. Has anybody read? Yeah. Okay. So I think what's happening in primary care is very much along the lines of the book, which is, you need to create enough momentum to kind of get everybody doing it. And you're going to have different stages. You're going to have people that adopt early, and obviously Tobias Gelber and I are early adopters if you look at the model of change. And you're going to have late adopters. And it doesn't matter what the field you're talking about, what industry you're talking about, you're going to have those people. And all you can do is start with the early adopters and move towards the people that will kind of adopt on the basis of what they've been able to achieve, and eventually reach the tipping point where the system change is so widespread the late adopting guys can't hold on to it anymore. And so I actually have given an hour lecture on resisting change, in terms of, especially directed in terms of physicians resisting change. And what you have to get down to is you have to get down to what's important to the docs and why they're resisting the change. And as Nuala said, that some of those fears there, right? And you have to address those concerns and fears. But the vast majority of physicians want better care for their patients. There are those who are financially motivated. There are those bad apples in the box, as you said. And that's true of any industry as well. But I truly believe the average doc who does primary practice wants to help their patients. And if you boil things down to why they're resisting change and trying to address the actual concerns around that, I think that's how you motivate those late adopting people to change. Plus, you put resources into the people that are willing to change, willing to try things out. And you create the business case, and you create the data, and you create the patient care case that makes it impossible for someone to say no.
I guess I'll stay up here so I don't have to get up and down. I thought you were brilliant in the first part of your talk by asking the question, think of things that if they hadn't changed in the past 30 years, right? I mean, those images were like phenomenal. The computer, I love that because I use the big old original, multi-room, gigantic computers. And now look what you've got, little smidgy thing. And everybody's got them. Kids have them in their back pocket. The fact of the matter is, in real terms, I think docs have to begin to think, see, there is something that's 2,400 years old, that's real and true. But lots has changed in how we make that happen. And so the reality is, and your empirical stuff is the system stuff that I know, while we've been demonstrating all these things, there's been very little real change. The number of docs, they may have a couple of other docs in their group, but they're functioning exactly like the normal Rockwell doc, individual docs, individual patient, trying to do everything for individual patients when it is humanly impossible to meet the expectations by a single person, no matter how good a doc you are, because the expectations for proper care in this day and age have been exceeded. So you're killing yourself trying to do it all. because there's something that in this, the Kenny spot, that's important and true, but you think the only way to keep that is to keep doing it the same way, when everything else around you necessary for optimum patient care has changed. So it's like you're sitting in a room with the doc still doing everything, and the computer's getting smaller, and it doesn't make any, the doc is still, it's like, it's almost like the story of the extinction of the dodo, right? If you can't adapt to the circumstances around you, you in fact will not survive. I mean, that's the story, right? So the flip side of that empirical reality about change is, can we demonstrate, and that's why I love the stuff you presented, can we demonstrate for good docs that we can make these changes, that we can participate in teams and still maintain our integrity, still maintain that something special about the doctor-patient relationship and trust, and fulfill our commitment to patients' best interest? Because it's that little part. I mean, there are people who are just resistant, and there are people who are making $1 billion and they don't want to move anything, even though their health is being adversely affected and perhaps their care of patients is way suboptimal. But that's different. They're, I think, rare birds. But the ones that are holding on to it, there's something good that's at the core of their resistance, and they have to be reassured. They have to be reassured that professional integrity and patient best interest, both of those things. So the doc's not the only one that's special, but the doc stays special, and that relationship stays special. If anything, it's like error in medicine. What we learn, I mean, I was chief at the hospital, we had a disastrous thing, you know, a death of a child who had been injected by vincristine intrathecally instead of intravenously. And you know, they were saying, how do we deal with this? There's only one way you deal with that. You go totally public, you're totally transparent, and the reality is, all the literature shows that when docs make a mistake, when nurses when we make a mistake, we enhance trust by saying that's what happened, okay? Or when we say, look, I don't know what's going on here, but I know folks who'll help me figure it out. I'm going to get right on the phone now, and I'm going to go call one of the pediatric cardiologists because this is too much. You're not diminished in the eyes of the patient by that. They trust you more because they know, hey, she's good, but she's not. She recognizes that she needs help. That is an enormously affirming thing for patients, though docs, with their tremendous sense of responsibility to know it all and do it all and fix it all, can sometimes, it's like death. Think of it as a failure when in fact it was inevitable. So some of what this is about is enough empirical evidence that patient care is better, and that in fact still the relationship with the doctor has been preserved. If anything, it's been improved. Because instead of 4 minutes in and out on a conveyor belt, patients can actually have an opportunity for a conversation that's more meaningful. You're using the expertise of the doc, all of that clinical judgment, all of that commitment to patients in a new way. So, I mean, resistance is hard. Some are just resistant because that's their genetic makeup, but there's something else going on here, and I think some of these demonstrations will help us with the docs. Good docs, but need to be reassured.
I think just one more thing is that data is incredibly compelling to docs. So one thing I know for sure is that docs as a whole do a great job if someone comes in for a physical. Like, they really do. They go through everything. Screening rates are high. They generally do a really good job. But if you present a doc with a piece of paper that says, did you know you only offered 40% of your panel colon cancer screening of any kind, docs take that to heart, you know, because they want to do a good job. You know, and you don't have to publicly throw it up and say, oh, look at this guy, he only did 40%. You know, all you have to do is send it to the doc, because that's the biggest bang for the buck.
Okay, thank you. I don't know if I should do this, but I'm going to push you a little bit more on this path. Both of your comments were great, and but I want to talk about professional misconduct and contravening your professional code or misconduct professionally. If Norman Rockwell was practicing out in Black Diamond with his little black bag, just like the guy in the painting, didn't work with anybody, still worked out of everything in the black bag, at what point do we say, well, they're just a late adopter, or we can, tipping point stuff, they need data? But at a certain point, when do we say there's enough of this, it's professional misconduct, and it's a big problem? Like where's that line?
Yeah, okay, I see what you're pushing here. A little resistance is human, but a certain kind of resistance to the change that we have evidence improves patient care now becomes reprehensible, right? That's what you're at that line, right? I think it's true. The example that I used a couple of times was because of the importance of evidence. And yet, remember, evidence is not a cookbook. Scientific evidence, I link evidence and evidence-based medicine with clinical judgment, right? That evaluation and the evaluation in the light of the individual patient, because that's the genius of the doctor-patient encounter. So I kept using the example of docs who have an idiosyncratic response to the disease. I've always used chloramphenicol. I'm going to continue to use it. We would say that is not standard of care. We would have a common collegial response to say this is no longer optimum care for this condition, right? That's how we would do it with an individual problem. I think that the information, and you're absolutely right, docs do pay attention to data. The information about how these things work well to enhance patient care, enhance communication, and even better access to more appropriate use of doctor's time, we don't have that yet as standard of care, right? We have that as new and emerging data. That's the way I would put it, right? You did a tipping point, I'll do it that way to make the medical analogy. I think there will come a time, I'm convinced, and even without having heard my colleague here, just in general terms of what I know about health systems, about the importance of primary care reform, central. But there's still huge resistance across the profession, including across primary. Lots of people have an intuition. So I don't think we're ready yet to say this is misconduct or failure of standard of care as a general rule. But the data is all pointing in the direction of, hey, it's soon going to be a standard of care that is inappropriate for the most efficient and effective care in the 21st century. So it's getting there, and thank God for you folks and folks who keep data and track data, and because you have to demonstrate this. That's what the demonstration projects have to show, the things that really do make a difference to patients, but that are not just a new drug, a new device. They are new ways of delivering care. At some point it will become that, but I don't think it's there yet, dear.
Yeah, I'm not sure we'll get there in my lifetime, to be honest, or my career in medicine. The systems are very slow to change. What do you need to say back there, Jamie? Yeah. So the slope that you're going down is a very slippery one, right? And so I'm going to push even farther. I think, you know, the older doc who's resistant to change, who wants to do his own thing, but is still doing his best in terms of himself or the patients, is no worse than the new doc working in the walk-in clinic who shows no responsibility to patient care whatsoever. In fact, that is by far, the old resistors are not the system problem. The new walk-in guys are the big system problem, especially in big centers. It's less of an issue the more rural you get, but at big centers it's an issue. So the question is, how do you change that culture? Because unfortunately they're becoming the predominant culture in primary care, you know, instead of the exception in primary care. And I think patient advocacy is going to get us there. And, you know, I'm going to say that fee-for-service, getting rid of it, would get us there too. So rather than paying because you happen to see a patient and you didn't actually do anything for him, but you refill his prescription, versus the guy who actually did all the screening, all the management, managed the chronic disease, and those two things pay the same amount, is totally ludicrous. And I think that eventually is going to be taken out of docs' hands if we can't sort it out ourselves. And we're seeing some of that in Ontario now with what's happened. So if the AMA and docs as a group can't find a way to sort it out, it's going to get sorted out for them. And maybe that's the driver that tips things over the edge.
And if you go to the things that we should resist, and his point about some younger, newer docs who, and somebody pointed this out at coffee, some younger, newer physicians are actually more oriented towards team mentality because they didn't have this long tradition of solo. That's good stuff. But I could not agree with you more, because what they want is a constrained hour job. Okay? And what are the things that this specific hours, nothing else beyond that kind of approach, what are the things that we need to resist? Well, this does not improve collaboration and coordination across the system. These are isolated. I mean, sometimes you don't even get a report that these things happen. Does it support better communication with the patient? Does it support better continuity of care? In other words, this is a nice example I tried to allude to, and I actually have even better examples now that I heard Dr. Beller, that there are things we're doing, choices we're making. We blame systems, we blame government reorganized. We're doing some things ourselves as members of the profession that are eroding the nature of professionalism and adversely affecting us because we're not resisting changes that in fact are deteriorating continuity, deteriorating communication, adversely affecting collaboration. And then at the end of the day, we know that the more fragmented the care, the worse the care is. We know that. We know that. We know that. So a really good point about youngers. Was it Jamie that was talking before? Okay. Jamie reminded me of something that your slide showed that was wonderful again. If you look at the slide where we were shown the kinds of things that other members of the team do to help make the doctor team work better, in the old doctor-patient relationship, the doctor wasn't seeing a patient for cigarette smoking cessation. The doctor was seeing the patient for a cough. The doctor was seeing the patient for a high temperature. The doctor was seeing a patient for a sore knee. That approach was only immediate individual symptom response. Part of what's happened in our understanding about what really matters for health and well-being is all this other stuff. There's no way any physician alone can deal with nutrition and lifestyle and exercise and smoking, right? So if you put it all together, part of what doctors have to understand is if we were still the computer that takes 62,000 square feet, we would actually not be serving as well as the little tiny thing that you've got in your hand, because we're still focusing on things that, I mean, as I said when I was teasing about even being a pediatrician and teaching nutrition, there are some things we're just not the best people at. that. So we can't even do our job well because we're not allowing those who have better expertise. But it's a different way of thinking of what is that encounter about. And I think, quite frankly, family medicine's been fantastic. Family medicine and palliative care are my two favorite areas of medicine these days for different reasons. But family medicine really, really, really done well says this is not just about individual encounters with prescriptions and investigations. This is about relationships and total understanding of what makes for health and well-being.
Okay, thank you. We wouldn't have one of the leading health ethicists with us without taking an opportunity to ask a question or two about justice, and the questions that were submitted were in that realm. So we'll be shifting a little bit there. Physician as gatekeeper has been brought up, where access to specialty clinics, triaging things is left with the family physician. We saw in Brad's presentation the baby boom. I'm right at the farthest point out, so my calling in my career is to fix the bloody system before I need it, because another 20 years from now I want somebody to take care of me, and right now it's impossible. So we do have this amazing pressure in the Western world facing us. So if I'm being referred to the clinic and I need an MRI, I can wait 3 or 4 months because the clinic wants the MRI before, or I can just go and pay. So a question of justice. There's another question of justice here, and this is getting much more to the physician role. And when I studied medical ethics, it's that physicians need to balance the interest of the patient somewhat with what society can afford, and how do we balance that and deal with that tension as we go forward. Right now, you know, we can give a lot of things to the people in the older echelons because there's not that many of them. When I'm that age, there's no way. We know that the aging population and chronic disease will implode the entire acute care system. So how do we strike that balance? And this is an easy question, Nuala, easy. How do we strike the balance? What's the physician role? And how do we deal with this? And I'm sure Brad might have a thought or two.
Yesterday, I was in Lethbridge, and the Good Samaritan Society, some of you will know that, Lutheran, historically Lutheran-based, had their annual, they have an annual day on spirituality and health or something. I gave 4 lectures yesterday, nearly killed me. The 2 in the afternoon, one was on justice, compassion, and the continuum of care. And I showed aging demographics. I used different slides than Brad, but making the exact same point. And the very last lecture was justice at end of life. So it's the importance about the expenditures that we're giving in the last 30 to 90 days of life. And while they are huge and increasing in all 3 trajectories of dying, the cancer trajectory, the chronic disease, COPD, congestive heart failure trajectory, and the frailty and dementia, all those 3 trajectories of dying, increasingly aggressive, increasingly expensive interventions in those last 3 months, 1 month of life, in the face of inevitable dying, for a benefit that is infinitesimal at most. Okay? So we're spending huge amount, 21% of the Canadian expenditure is in that last 6 months of life, and a third of that is in the last month of life. Is it giving good hospice and palliative end-of-life care? Not at all. So there are some huge questions about the use of science and technology in the face of inevitable dying. But this is I have a lecture, and the beginning of the lecture I say, I'm now going to show you, it's about justice and fairness in healthcare. I'm now going to show you the patron saint of justice and fairness in healthcare. And do you know who I show them? Buzz Lightyear. Those of you who are not parents or grandparents or pediatricians, okay, so those of you who do know, Buzz's phrase is, to infinity and beyond. Duh. Do you know most people don't understand the irony of that expression? It's like, well, of course, to infinity. To infinity is it. There ain't no beyond infinity. But the expectations of modern medicine, the expectations we have, it's a very complicated issue, justice issue, okay? But what I'm saying is these are big questions. This is what, in light of this conversation and this group, that I need to be very clear about. The doctor's duty is to make the recommendation she deems is the best possibility of benefit with the most limited risk and harm, and make that recommendation to the patient. The doctor does not ration at the bedside. Now, whether or not a system can provide what the doctor believes is the best. Now remember, also in reasonable judgment, whatever. But the doctor's decision is to take this calculus of benefit and harm and make the recommendation for the patient. You don't say, nah, you're 83, you're not worth it. Absolutely contravenes the doctor's obligation to patient best interest. What we don't do well in all common systems is make it clear that I'm not the one who says you can't have this new super fantastic expensive drug. If I thought it was the best, and hardly ever do I think the newest and best, the most expensive works, but occasionally it might happen, I recommend it, and then I go advocate for my patient. But I don't change the judgment I make for my patient. Individual docs need to make reasonable decisions. Remember, one of the CMA, make medical decisions prudently. Prudently. And of course, prudence is not a word. Buzz Lightyear wouldn't know what prudence was if he flew over it, right? So, but let's be clear that it really is important when we talk about the social responsibility of medicine. We do have a responsibility to advocate for good quality, fair, efficient, effective. But that doesn't, you know very well, that does not mean some of these new expensive, annualized for a year of life saved. I mean, we're talking things like for Avastin, colorectal cancer. You want to look at that one? $85,000 annualized per year of life saved for what is for most patients, at best, 1.5 to 3 months of prolonged life over against expenditures that have already been in the hundreds of thousands of dollars. And if you give this $80,000 course to this one individual for, at best, less than 3 months and a variable quality life, who didn't get something from that $80,000 expended? So that's a society, that's a doctor advocacy issue. It's not a doctor-patient issue.
But, you know, at the same time, I think some of those issues on cost expenditures and injustice in the system are because of eroding relationships between family docs. I'm going to go back. The continuity thing is a big soapbox for me. You know, continuity in relationship with patient. And I can't tell you the number of times that I've seen patients who went to the Cross Cancer, they were at the U of A, they had surgery done, and they had RT done, then they had chemotherapy done, then they were on their second case of chemotherapy, then they transfer them to the Red Deer Hospital for the third trial of the $80,000 drug for chemotherapy, and I go and I say, you know, it's my patient, I said, you know, why are you doing this to yourself? And they say, well, nobody ever told me I was going to die. Right? But how do you tell somebody they're going to die if you don't know them from a hole in the wall? And how do you tell somebody who comes in with a sore ankle saying they need to see an orthopedic surgeon that they don't if you don't have a relationship with them? And you can say, you know, no, you have a ligament injury, you know, you can go to rehab and I'll see and follow up. If we need to do that, we'll do it later. But without a relationship, you just say, okay, and you write the referral. Or you do the test, you know, or you sign off on the treatment. And so the lack of continuity and the lack of doctor-patient relationship is, you know, destroying our system from a justice perspective as well. There's another question that was handed here is, what is the key unit of team communication in my clinic success, and who leads and initiate, and is there a format? So I have a presentation on this too. No, I I do have a presentation on team effectiveness, and so the key unit in my clinic is a weekly team meeting. This occurs for 1 hour every week. The clinic is closed for that 1 hour, and we have a message on our machine that says your team is working to better your care and in a meeting from this time to this time. Everybody in the clinic at the time, docs, nurses, receptionists, expect to be at the meeting. We have a very specific agenda for the meeting. This agenda was agreed upon by the team. We had a team day where we sat down and said, what important things do we need to talk about on a weekly basis to move our team advancement forward? We came up with the format on a half-day team building exercise. We stick to the agenda. The agenda deals with kind of red flag issues. It deals with issues from each discipline. It goes through current ongoing improvement initiatives and the results, and it looks at data in terms of access and practice quality improvement, and we have action items for the next meeting. We commit that the meeting is never going to run over time. We commit that the meeting is going to have value for everybody that attends, and we commit that as a group, if there's not value, that we discuss that as a group and rework our format. So that's how the weekly team meetings kind of operate, in my clinic.
Thank you. So there was a question about handouts being available, and yes, they will. And there's a camera back there, so as John Stewart often says when his program is running out, that we're going to throw it up on the web. So both speakers have agreed to allow us to squeeze some of the wisdom of this morning. And quite frankly, I was very disappointed with participation in this session. Certainly, I look across here, seeing Michelle and Kay and a bunch of you that are working in the system, and you see where things have to go. We invited 140 family physicians to this session. 17 are here. That's not very good. That's why we're going to put it up on the web and maybe encourage them. Physicians had plenty of notices. Notices went out 3 months ago. I had lunch with Nuala last spring to twist her arm to come here. We offered to pay physicians for the time here because I recognize you have overhead. Now, rather than you learn in graduate management school that never be mad at people because that's not going to get you very far. It is problematic over time, but you can be angry with systems. And the perversity of our system, if we went into Okotoks and we restructured the banking system here like family medicine is restructured, if Gloria wanted to make a deposit, she'd have an appointment with the bank manager. She couldn't see anybody else. If she wanted to make a withdrawal or get an RSP. So we put the bank manager that has to see everybody who has a banking need. There's no other access. So the system is, and we talked about fee for service, and it's beyond being a joke for how it makes good people work. And good people work very poorly with bad outcomes. So we need something to do for that, because I've had doctors often say, I'd love to come to your session, but it costs me $50 an hour just not to be there. And it's not even the money that's the issue. It's the backup of people who want to make deposits on Monday because they didn't. The doc took a few hours to have a chance to talk about stuff like this. So this is why, we've recorded these sessions. Every one of the physicians is going to receive links. And if it takes to pay them, to watch them, to be able to think about these matters, we're going to do that because they fundamentally are the leaders that are going to move the clinics forward. I don't need to convince people like Kay of what needs to happen in Black Diamond, but we do need to convince people about how to improve the system. So I want to very, very much thank both speakers for joining us. It was the outcome was better than I had thought, so thank you very much. We will make the slides available to you and throw up the YouTube on the web. We'll give all credit where credit is due. And there's really one unfortunate thing. I didn't want to finish this morning on a bad note, but unfortunately it's Paula Zacharias' birthday today. And with my singing voice, there would be no question that we would end on a bad note. So to avoid that, what I'm going to do is just say 1, 2, 3. I'm going to step away from the microphone. I will start to sing, but you won't hear the bad note. One of you in here with an angelic voice will start the happy birthday. Fair enough? 1, 2, 3. And I will be taking Nuala in a few minutes. There will be lunch to pick up and a chance to informally chat with the speakers. There was one question I didn't get to, but it had to do with, I'll mention it to everybody, but had to do with the kind of the pre-selection visit. So you phone the doctor's office, you're taking patients, and they say, we're going to have a meet and greet. So the person who asked that, I didn't get to get Nuala to address it, but you can please approach her to ask, because I've heard that kind of meet and greet. Well, what it means is if you're old and sick, you probably don't meet again. If you're young and healthy, you may meet again, but I'm not sure. Thank you very much, everybody.